Welcome to this Q&A session for the WGU Adult Health III exam. We'll work through authentic practice questions, breaking down why the right answer holds up, why each wrong option fails, and the theory behind it. This video covers Domain 1, acute GI, vascular and toxicologic emergencies including pancreas, liver and aorta anatomy and function, presentation and management of acute pancreatitis, the course of chronic pancreatitis, formation of an abdominal aortic aneurysm, effects of acetaminophen toxicity, and don't forget, our website offers free study guides and practice questions designed to help you pass your D454 exam with confidence. Just click the link in the description below to access everything you need. It's completely free, so take advantage of it and study smarter, not harder, to reach your goals. Alright, let's dive in. Question 1. A patient is admitted with severe epigastric pain, persistent vomiting, and a serum lipase 5 times the upper limit of normal. The provider explains to the family that the pancreas has begun to digest its own tissue. Which event initiates this process? Your options are: A. Enterokinase is released into the pancreatic duct from the gallbladder. B. Bicarbonate secretion from the ductal cells falls below the level needed to buffer gastric acid. C. Trypsinogen is converted to active trypsin inside the pancreas rather than in the duodenum. D. Insulin production from the islets of Langerhans stops abruptly. Which one is it? Pause the video if you need more time. The correct answer is C. Trypsinogen is converted to active trypsin inside the pancreas rather than in the duodenum. C is correct because acute pancreatitis begins when trypsinogen is activated to trypsin within the gland itself instead of in the duodenum. Active trypsin then converts the remaining zymogens to their active forms and autodigestion follows. Every risk factor for pancreatitis ultimately converges on the single event. A is wrong because enterokinase is produced by the duodenal lining, not the gallbladder, and it does not travel backward into the pancreatic duct. Its confinement to the duodenum is exactly what keeps enzyme activation out of the pancreas. B is wrong because reduced bicarbonate secretion would affect neutralization of acidic chyme entering the small intestine. It does not activate proteolytic zymogens and does not trigger autodigestion. D is wrong because loss of insulin production causes hypoglycemia and does occur as pancreatic tissue is injured. It is a downstream consequence of gland destruction rather than the initiating event. Acute pancreatitis has exactly one initiating event, and everything else about the disease sits downstream of it. Trypsinogen gets converted into active trypsin while still inside the pancreas, instead of after it reaches the duodenum where that conversion belongs. It is the right enzyme in the wrong place at the wrong time. Trypsin does not act alone, and that is what turns a small error into a catastrophe. Active trypsin is the master switch that converts chymotrypsinogen to chymotrypsin, pro-elastase to elastase, and activates phospholipase A2. Elastase then attacks blood vessel walls causing bleeding. Phospholipase A2 dismantles cell membranes, and lipase releases fatty acids that bind calcium. The pancreas builds its enzymes inactive on purpose, because no enzyme can be selective enough to digest a steak but spare the gland that made it. Activation is meant to happen only in the duodenum, triggered by enterokinase, an enzyme the duodenal lining makes and keeps to itself. The pancreas never holds the key to its own weapons. Gallstones, alcohol, high triglycerides, medications, procedures, and trauma are all causes, and the list is long. But every one of them funnels into the same mechanism of premature trypsin activation inside the gland. Different doors, same room. Once autodigestion starts, nothing in the treatment arsenal can stop it, which is why care is supportive rather than curative. Remember that the inflammatory cascade and chronic fibrosis are separate later chapters, not this initiating event. Trypsin activation inside the pancreas is always the first act. Question 2. A nursing student asks why the pancreas does not normally digest itself, given that it manufactures enzymes powerful enough to break down protein. Which explanation is most accurate? Your options are: A. Protein digesting enzymes are stored and secreted in an inactive zymogen form and are activated only after reaching the duodenum. B. The pancreas secretes only amylase and lipase, while all proteases are manufactured by the duodenal wall. C. Bile flowing from the common bile duct coats the pancreatic duct and blocks enzyme contact with pancreatic tissue. D. Pancreatic tissue lacks the surface proteins that digestive enzymes must bind before they can break down a cell. Take a second. Which answer would you pick? The correct answer is A. Protein digesting enzymes are stored and secreted in an inactive zymogen form and are activated only after reaching the duodenum. A is correct because the proteases are synthesized and stored as inactive zymogens such as trypsinogen and chymotrypsinogen. Activation is deliberately postponed until the enzymes reach the duodenum, where enterokinase converts trypsinogen to trypsin. The pancreas also produces trypsin inhibitors to neutralize any enzyme that activates prematurely. B is wrong because the pancreas manufactures all three enzyme classes, including the proteases trypsinogen, chymotrypsinogen, proelastase, and procarboxypeptidase. The duodenum contributes enterokinase, not the proteases themselves. C is wrong because bile and pancreatic juice share a drainage point at the ampulla of Vater, but bile does not line or shield the pancreatic duct. Bile refluxing into the pancreatic duct actually helps trigger pancreatitis rather than prevent it. D is wrong because pancreatic cells are made of the same proteins and lipids these enzymes digest, which is precisely why autodigestion is possible. Protection comes from delayed activation, not from immunity at the cellular level. The pancreas makes up to 2 liters a day of enzyme strong enough to dissolve protein, yet it never digests itself. That safety record depends on 3 overlapping layers of protection working together. Protein digesting enzymes are built as inactive zymogens, molecules with a blocking segment still attached. The ogen or pro in each name signals a loaded weapon with the safety on, unlike amylase and lipase, which are secreted already active. The second layer is geographic. Activation only happens in the duodenum, far from the gland itself. Enterokinase from the intestinal lining converts trypsinogen into trypsin, which then triggers every other zymogen in a controlled cascade. The third layer is a backstop. Trypsin inhibitors neutralize any enzyme that activates prematurely inside the gland. This means pancreatitis is a threshold problem, not a switch, occurring only when premature activation overwhelms the inhibitor's capacity. Enterokinase is the linchpin. Knowing it lives in the duodenum explains why raised pressure in the pancreatic duct, like from ERCP, can push activation past what inhibitors can contain, causing pancreatitis. Question 3. A patient with acute pancreatitis reports steady, boring pain in the upper abdomen that travels straight through to the back. The abdominal exam reveals surprisingly little guarding or rebound tenderness. Which anatomic feature best explains this presentation? Your options are: A. The pancreas shares its arterial supply with the descending colon. B. The pancreas lies directly beneath the diaphragm within the right upper quadrant. C. The head of the pancreas is wrapped in the peritoneal lining of the stomach. D. The pancreas lies retroperitoneally behind the peritoneal membrane. Before I reveal it, which one do you think is right? The correct answer is D. The pancreas lies retroperitoneally, behind the peritoneal membrane. D is correct because the pancreas sits behind the peritoneum in the upper abdomen, so inflammation irritates deep posterior structures and refers pain straight through to the back. Because the peritoneal surface is not directly involved early on, guarding and rebound tenderness may be minimal. A deceptively soft abdomen does not rule out serious pancreatic disease. A is wrong because shared arterial supply with the colon is not the relevant anatomic relationship and would not produce posterior radiation of pain. The colon receives its blood from the mesenteric arteries rather than the pancreatic branches. B is wrong because the organ that occupies the right upper quadrant beneath the diaphragm is the liver. The pancreas lies transversely across the epigastrium and left upper quadrant behind the stomach. C is wrong because the pancreatic head sits within the C-shaped curve of the duodenum and is not enclosed by stomach peritoneum. An intraperitoneal position would produce more peritoneal signs, not fewer. Severe pain, a soft belly, no rigidity. That mismatch is not confusing exam findings. It is anatomy, and it is one of the most important facts about the pancreas. The pancreas sits deep behind the peritoneal lining, tucked transversely across the upper abdomen with its head cradled by the duodenum and its tail reaching toward the spleen. That hidden posterior position changes how disease here behaves. Because the pancreas is walled off retroperitoneally, three things follow. Pain radiates straight through to the back with a boring, penetrating quality. The abdominal exam stays deceptively soft, since peritoneal signs need surface irritation. And days later, escaping blood tracks through retroperitoneal planes to produce visible bruising. Flank bruising is Gray-Turner's sign. Periumbilical bruising is Cullen's sign, and both simply mean blood is loose in the retroperitoneum. A ruptured aortic aneurysm bleeds into that same compartment and produces the identical signs, because the sign belongs to the space, not the disease. Unlike peritonitis, where patients lie rigid and still, the pancreatitis patient keeps repositioning, curling forward, hunting for relief. Watching what the body does is free diagnostic information. Question 4. A patient with severe necrotizing pancreatitis has a total serum calcium of 7.1 mg/dl and reports tingling around the mouth. Which process best accounts for the calcium result? Your options are: A. Repeated vomiting has caused loss of calcium-rich gastric secretions. B. Free fatty acids released by lipase bind serum calcium in a process called saponification. C. A surge in parathyroid hormone has driven circulating calcium into bone storage. D. Aggressive resuscitation with lactated ringers has diluted the serum calcium. What's your answer? Commit to one before I continue. The correct answer is B. Free fatty acids released by lipase bind serum calcium in a process called saponification. B is correct because activated lipase breaks fat down into free fatty acids in and around the inflamed pancreas. Those fatty acids combine with calcium to form soap-like complexes, consuming circulating calcium and producing hypocalcemia. The degree of hypocalcemia tracks with the severity of necrotizing disease. A is wrong because gastric fluid is not a major calcium reservoir, and vomiting alone does not lower serum calcium to this degree. Vomiting more typically produces losses of hydrogen, chloride, and potassium. C is wrong because falling serum calcium stimulates parathyroid hormone release, which pulls calcium out of bone rather than into it. The hormonal response opposes the hypocalcemia rather than causing it. D is wrong because lactated ringers actually contains calcium and is the preferred resuscitation fluid in pancreatitis. Dilution from crystalloid does not explain clinically significant hypocalcemia with neuromuscular symptoms. Severe pancreatitis can drop calcium to dangerously low levels, and the parathyroid glands are completely innocent. The real explanation is a chemical reaction inside the abdomen that borrows its name from soap making. Activated lipase escapes the damaged pancreas and splits surrounding fat into free fatty acids and glycerol. Those fatty acids grab circulating calcium and precipitate as insoluble calcium soaps in the necrotic fat, the same chemistry that turns fat and lye into soap. This gives hypocalcemia in pancreatitis a unique meaning. Calcium isn't lost through the kidneys, sequestered by hormones, or diluted by fluid. It's being consumed by an active destructive process. That's why a calcium below 8 is one of the Ranson criteria, reporting the extent of necrosis rather than a simple electrolyte problem. Low calcium destabilizes nerve and muscle membranes, and the mnemonic CATS captures the danger: convulsions, arrhythmias with a positive Kvostek sign, tetany with a positive Trousseau sign, and spasms including laryngospasm. The airway and the heart are the two lethal endpoints, since severe hypercalcemia can close the airway or prolong the QT interval into torsades de pointes. A facial twitch on exam should immediately trigger cardiac monitoring, provider notification, and seizure precautions, with IV calcium gluconate ready to go. Charting the finding without escalating it is the error that cost patients. Question 5. A patient hospitalized with acute pancreatitis develops bluish discoloration along both flanks on the third hospital day. Which activated enzyme is most directly responsible for the bleeding that produces this finding? Your options are A. Amylase, B. chymotrypsin, C. elastase, D. Phospholipase A2. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Elastase. C is correct because elastase digests the elastic tissue within the walls of blood vessels in and around the pancreas. Once those vessels lose structural integrity, blood escapes into the retroperitoneal tissues and tracks to the flanks, producing Gray-Turner's sign. This is the mechanism behind hemorrhagic pancreatitis. A is wrong because amylase breaks down starches into simple sugars and has no effects on vascular walls. It is a useful diagnostic marker but not a driver of hemorrhage. B is wrong because chymotrypsin digests proteins as part of the autodigestive cascade, but is not the enzyme that targets vessel wall elastin specifically. Its activation contributes to general tissue destruction rather than to bleeding. D is wrong because phospholipase A2 damages cell membranes and works with lipase to produce fat necrosis. It contributes to tissue death, but vessel wall breakdown and hemorrhage are attributed to elastase. Bluish bruising on the flanks of a patient with pancreatitis is Gray-Turner's sign, and it means blood has escaped into the retroperitoneum. Tracing that bruise backward points to one enzyme and one tissue type. Elastase arrives inert as prolastase and trypsin activates it during the autodigestive cascade. Its target is elastin, the stretchy protein in blood vessel walls. And vessels near the pancreas take the brunt of that activated enzyme, so the walls fail and blood escapes. The other enzymes deserve their own consequences rather than being lumped together. Amylase splits starch and destroys nothing. Lipase splits fat and causes fat necrosis. Phospholipase A2 attacks cell membranes and causes gland necrosis. And elastase alone targets vessels, which is why elastase is the one that bleeds. Blood takes days to migrate along tissue planes to the skin, so these signs confirm established bleeding rather than announce a new one. Trending hematocrit tells the real story. A rise from plasma loss followed by a fall signals bleeding earlier than the bruise does. And because a ruptured aortic aneurysm produces the identical signs, the bruise reveals location, not cause. Don't confuse these with jaundice, which is yellow, generalized, and reflects bilirubin the liver can't clear. Bluish, purple, and focal means blood. Yellow and diffuse means bilirubin. And telling them apart fast is what matters most. Question 6. A patient admitted 12 hours ago with acute pancreatitis now has a heart rate of 124, a blood pressure of 86/52, and a urine output of 50 ml/h. The abdomen is distended and there is no external bleeding. Which mechanism best explains this hemodynamic picture? Your options are: A. Increased capillary permeability has allowed plasma to leak into the retroperitoneal and abdominal spaces, depleting intravascular volume. B. Circulating pancreatic enzymes have directly suppressed myocardial contractility, producing cardiogenic shock. C. Paralytic ileus has trapped fluid within the bowel lumen, which is the sole route of loss in pancreatitis. D. Hemorrhage into the biliary tree has reduced the circulating red cell mass. Which would you go with? Lock it in before the reveal. The correct answer is A. Increased capillary permeability has allowed plasma to leak into the retroperitoneal and abdominal spaces, depleting intravascular volume. A is correct because inflammatory mediators released in pancreatitis make capillaries leaky, and large volumes of plasma shift out of the vasculature into the retroperitoneum and peritoneal cavity. This third spacing produces profound intravascular depletion, even though total body water has not left the patient. Tachycardia, hypertension, and oliguria are the predictable result. B is wrong because pancreatitis produces hypovolemic and distributive shock, not primary pump failure. Cardiac output falls because preload is lost, not because the myocardium is poisoned by enzymes. C is wrong because ileus does contribute to fluid sequestration, but it is not the sole route of loss. The dominant mechanism is capillary leak into the retroperitoneal space, which can sequester several liters. D is wrong because biliary hemorrhage is not a typical feature of acute pancreatitis, and there is no evidence of blood loss in this scenario. Retroperitoneal bleeding, when it occurs, presents with flank or periumbilical bruising. In severe pancreatitis, a patient can look flooded with fluid and still be in hypovolemic shock. Understanding why requires separating two ideas: total body water versus the volume actually circulating in the vessels. Inflammatory mediators from the injured pancreas widen the junctions between endothelial cells. Plasma normally held in circulation by albumins pull leaks out into the interstitial and retroperitoneal spaces, sometimes 6 liters or more, in a process called third spacing. The fluid never leaves the body, it leaves the bloodstream, the only compartment that generates blood pressure and perfuses organs. Tachycardia, falling urine output, rising hematocrit, and climbing blood urea nitrogen are all downstream reports of the shrinking intravascular volume. Resuscitation is judged by endpoints, not volume given. Urine output near 30 milliliters an hour, a heart rate trending down, mean arterial pressure around 65 or above, and falling hematocrit and burn, but the same capillary leak threatens the lungs. So new crackles or falling oxygen saturation mean the fluid is now causing harm. This is hypovolemic and distributive shock from a leaking tank, not cardiogenic shock from a failing pump, and mistaking one for the other withholds the fluid that could save the kidneys. Question 7. A patient with a long history of symptomatic gallstones is admitted with acute pancreatitis. Which anatomic relationship explains how a gallstone causes inflammation of the pancreas? Your options are: A. The distended gallbladder rests on the pancreatic tail and compresses it. B. The pancreatic duct and the common bile duct merge at the ampulla vata, so a stone lodged there obstructs pancreatic outflow. C. Gallstones dissolve in pancreatic juice and release calcium that activates trypsinogen. D. Bile salts are absorbed by the portal vein and delivered directly into the pancreatic acinar cells. Don't overthink it. Which one feels right? The correct answer is B. The pancreatic duct and the common bile duct merge at the ampulla of vata, so a stone lodged there obstructs pancreatic outflow. B is correct because the main pancreatic duct joins the common bile duct at the hepatopancreatic ampulla before emptying into the duodenum through the sphincter of Oddi. A stone impacted at that shared outlet backs up pancreatic secretions and raises pressure inside the gland, and bile may reflux into the pancreatic duct. Both effects trigger premature enzyme activation. A is wrong because the gallbladder sits under the liver in the right upper quadrant, well away from the pancreatic tail near the spleen. Mechanical compression is not the mechanism of gallstone pancreatitis. C is wrong because gallstones do not dissolve in pancreatic juice and the calcium released would be trivial. Hypocalcemia can activate trypsinogen, but it comes from metabolic causes rather than from a stone dissolving. D is wrong because the portal vein carries blood from the gut to the liver, not from the liver to the pancreas. Bile reaches the pancreatic duct by reflux at the ampulla, not by way of the bloodstream. The gallbladder and pancreas are separate organs with no shared tissue, yet gallstones are the leading cause of pancreatitis. The answer isn't in the organs themselves, it's in a shared drain pipe they both depend on. Bile from the liver and gallbladder, and pancreatic juice from the pancreas. Both funnel into one shared channel, the ampulla of vata, before passing through the sphincter of Oddi into the duodenum. A gallstone traveling down the common bile duct can wedge right at that shared exit, blocking both outflows at once. Pressure builds, secretions stagnate, and bile can reflux into the pancreatic duct, triggering premature enzyme activation. Because bile flow is blocked alongside pancreatic flow, the labs leave a fingerprint, alkaline phosphatase rises, total bilirubin rises, transaminases often climb too, and jaundice appears if the blockage persists. A pancreatitis patient with these findings is announcing a biliary cause before any imaging is even ordered. Alcohol is the second most common cause, and together with gallstones it accounts for roughly 80% of cases. But the mechanism is completely different. Alcohol directly damages acinar cells and thickens pancreatic juice into duct clogging plugs, with no stone and no anatomic bottleneck at all. Getting the cause right changes the plan entirely, relieve the obstruction, support the inflammation, and remove the gallbladder to stop the stones from coming back. Skip that last step and the patient simply returns with the same problem. Question 8. 2 patients are admitted with acute pancreatitis. The first has diffuse pancreatic edema with a fully perfused gland on contrast-enhanced CT. The second has areas of devitalized pancreatic and peripancreatic tissue. Which statement correctly characterizes the second patient's condition? Your options are A. Interstitial edematous pancreatitis, which carries the higher risk of secondary infection. B. Chronic pancreatitis, since permanent tissue destruction is present. C. Biliary pancreatitis, which is defined by the presence of dead tissue. D. Necrotizing pancreatitis, in which the dead tissue may become infected and produce sepsis. Got a guess? Lock it in. The correct answer is D. Necrotizing pancreatitis, in which the dead tissue may become infected and produce sepsis. D is correct because necrotizing pancreatitis is the severe form in which portions of the gland and surrounding fat die rather than simply swell. Devitalized tissue is a culture medium, so infected necrosis and sepsis become real threats. This form drives the high mortality associated with severe disease. A is wrong because interstitial edematous pancreatitis describes the first patient, whose gland is inflamed but viable. That milder form carries a substantially lower risk of infection. B is wrong because chronic pancreatitis is a slow, fibrotic, calcifying process that develops over years. A single acute episode with necrosis is not the same entity, even though repeated attacks can eventually lead to chronic disease. C is wrong because biliary pancreatitis names the cause, meaning gallstone-related disease, not the morphology. A gallstone attack can be either edematous or necrotizing. Acute pancreatitis is written on two very different charts. The difference isn't severity on a sliding scale. It's a categorical split in what actually happened to the tissue. The mild majority form is interstitial edematous pancreatitis, where inflammation dominates but the gland stays alive and recovers with supportive care alone. The severe form is necrotizing pancreatitis, where portions of the pancreas and surrounding fat die outright. A categorical difference, not a matter of degree. Contrast CT works by showing which tissue still has blood flow, but necrosis takes time to declare itself, so a scan taken too early can look falsely reassuring, which is why the study is deliberately delayed roughly 48 to 72 hours after symptoms begin. Dead tissue has no blood supply, which means no immune cells and no antibiotic penetration reach it. So bacteria migrating from the nearby gut colonize it easily. Infected necrosis is the main route by which a pancreatitis patient becomes septic. That's why antibiotics are withheld until infection is confirmed, and why necrosectomy is deliberately delayed for weeks. Operating early on undemarcated necrosis is deadlier than waiting for it to wall itself off. In a field built on urgency, waiting is the intervention. Question 9. A patient with severe acute pancreatitis develops a rising respiratory rate, hypoxia that does not improve with increased supplemental oxygen, and bilateral infiltrates on chest X-ray. Which process best explains this pulmonary deterioration? Your options are: A. Aspiration of gastric contents during vomiting has produced a right-sided bacterial pneumonia. B. The nasogastric tube has migrated into the right main stem bronchus. C. Systemic release of inflammatory cytokines has produced a body-wide inflammatory response that injures the alveolar capillary membrane. D. Hypocalcemia has caused laryngospasm and upper airway obstruction. Which one is it? Pause the video if you need more time. The correct answer is C. Systemic release of inflammatory cytokines has produced a body-wide inflammatory response that injures the alveolar capillary membrane. C is correct because dying pancreatic tissue releases tumor necrosis factor, interleukin-1, and interleukin-6 into the circulation, producing systemic inflammatory response syndrome. Those mediators increase pulmonary capillary permeability, flooding the alveoli and producing acute respiratory distress syndrome. Hypoxia refractory to oxygen with bilateral infiltrates is the classic picture. A is wrong because aspiration pneumonia usually produces a focal, often right-sided infiltrate rather than diffuse bilateral opacities. It also tends to respond at least partially to supplemental oxygen. B is wrong because a misplaced nasogastric tube would produce immediate coughing and distress, and the finding would be unilateral. It does not cause diffuse bilateral infiltrates. D is wrong because severe hypocalcemia can cause laryngospasm, which is an upper airway emergency with stridor. It does not produce bilateral pulmonary infiltrates on chest imaging. Patients with severe pancreatitis sometimes die without ever developing an infection, and the pancreas itself is far too small to kill through organ loss alone. The real killer is what the dying gland sends into the bloodstream. Dying axonal cells and activated enzymes flood the circulation with inflammatory mediators, chiefly tumor necrosis factor interleukin-1 and interleukin-6. These dilate vessels, widen endothelial junctions, and activate neutrophils throughout the body, producing systemic inflammatory response syndrome from a sterile abdominal injury. The lungs suffer most because abdominal blood reaches the pulmonary capillaries early and at full concentration, and the alveolar membrane is exquisitely thin. Cytokine-driven permeability floods the alveoli with fluid so oxygen cannot cross, and raising inspired oxygen barely helps, defining acute respiratory distress syndrome. The revised Atlanta classification ranks severity by organ failure, not pancreatic damage. Mild disease has none. Moderately severe disease has transient failure, resolving within 48 hours or local complications, and severe disease has organ failure persisting beyond 48 hours, the strongest predictor of death. A left-sided pleural effusion is a common, less lethal companion finding worth listening for. Fever, tachycardia, and leukocytosis can mimic sepsis with no organism present, which is why cultures and imaging, not vital signs, decide whether antibiotics are needed. In the end, it is the systemic inflammatory storm, not the state of the pancreas itself, that determines whether the patient survives. Question 10. A patient hospitalized with acute pancreatitis and no history of diabetes has a blood glucose of 248 mmHg and DL. Which explanation should the nurse provide? Your options are: A. Inflammation has impaired insulin release from the beta cells, while stress hormones simultaneously raise blood glucose. B. The damaged pancreas has begun overproducing glucagon to compensate for lost enzyme output. C. Bowel rest during NPO status causes a rebound elevation in circulating glucose. D. A markedly elevated serum lipase interferes with laboratory measurement of blood glucose. Take a second. Which answer would you pick? The correct answer is A. Inflammation has impaired insulin release from the beta cells, while stress hormones simultaneously raise blood glucose. A is correct because inflammation injures the islets of Langerhans, and the beta cells that make insulin are among the casualties. At the same time, the stress response floods the circulation with catecholamines and cortisol, which raise glucose. The combination produces the transient hypoglycemia seen in acute pancreatitis. B is wrong because alpha cells do secrete glucagon, but there is no compensatory glucagon surge tied to loss of digestive enzyme production. The endocrine and exocrine functions are regulated separately. C is wrong because withholding food lowers glucose intake rather than raising blood sugar. NPO status is used to rest the pancreas and does not explain hyperglycemia. D is wrong because lipase does not interfere with glucose assays, and there is no laboratory artifact here. Treating a real hyperglycemia as a lab error would delay needed insulin. Glucose above 200 on admission is one of the 5 Ranson criteria, so it's not just a number to fix. It's prognostic information the pancreas is giving you. The pancreas does 2 jobs in one organ. 85% is exocrine tissue-making enzymes, but scattered through it are islets of Langerhans, beta cells making insulin, alpha cells making glucagon, and delta cells making somatostatin to restrain both. Inflammation from autodigestion damages beta cells, the most abundant islet type, cutting insulin exactly when it's needed most. At the same time, pain and systemic stress release catecholamines, cortisol, and glucagon, so the patient is hit from both directions at once. In acute pancreatitis, this hyperglycemia is usually temporary. Beta cells recover once inflammation resolves. In chronic pancreatitis, fibrosis destroys beta cells for good, producing lifelong pancreatogenic diabetes, sometimes called type 3C. Chronic pancreatitis also destroys alpha cells, so patients lose glucagon, their main defense against low sugar, making hypoglycemia a real danger and pushing targets looser than usual. Question 11. A nurse is reviewing the charts of 4 patients newly admitted with acute pancreatitis. Which patient history represents the single most common cause of the condition? Your options are A. A 44-year-old taking a thiazide diuretic for hypertension. B. A 29-year-old who underwent endoscopic retrograde cholangiopancreatography 2 days ago. C. A 51-year-old with a fasting triglyceride level of 1,240 mg/dl. D. A 62-year-old with known cholelithiasis and right upper quadrant pain after fatty meals. Before I reveal it, which one do you think is right? The correct answer is D. A 62-year-old with known cholelithiasis and right upper quadrant pain after fatty meals. D is correct because gallstones are the leading cause of acute pancreatitis. A stone migrating out of the gallbladder can impact at the ampulla of vata and obstruct the shared outlet of the pancreatic and bile ducts. Together with alcohol, gallstones account for roughly 80% of all cases. A is wrong because thiazide diuretics are a recognized drug cause of pancreatitis, but medication-induced disease is uncommon compared with biliary disease. The nurse would note the drug and expect it to be stopped, not treat it as the typical cause. B is wrong because pancreatitis after endoscopic retrograde cholangiopancreatography is a well-described complication, but it affects only a minority of patients undergoing the procedure. It is a known cause, not the leading one. C is wrong because triglycerides above 1,000 mg/dl can precipitate pancreatitis through toxic free fatty acids. This is an important cause to recognize and treat, but accounts for a small share of admissions. 2 causes explain roughly 80% of every acute pancreatitis case. Gallstones lead and alcohol follows. Everything else on the long list of triggers splits the remaining fifth, which is why knowing this ratio tells a clinician exactly where to look first. Gallstones cause disease through an anatomic accident. A stone impacts the shared duct, raising pressure and letting bile reflux into the pancreas. Alcohol works differently, directly damaging atenyl cells and triggering premature enzyme activation. Both roads end at the same result, enzymes turning on inside the pancreas itself. A single gallstone lodged at the ampulla of vata can block both the bile duct and the pancreatic duct at once, since they share this final common pathway before draining into the duodenum. That shared anatomy is the entire reason gallstones cause pancreatitis. Once gallstones and alcohol are excluded, the worker pivots to the second tiers, triglycerides, medications like valproic acid and thiazides, recent ERCP procedures, hypercalcemia, and trauma. Each of these carries its own specific fix, which is exactly why naming the cause is part of treating the disease. The common mix-up is confusing acute with chronic disease. Gallstones dominate acute pancreatitis, but chronic alcohol use dominates chronic pancreatitis, because a stone causes one discrete obstruction, while alcohol causes injury that accumulates over years. Question 12. A patient with pancreatitis has no history of alcohol use and a normal abdominal ultrasound showing no gallstones. Which laboratory result would most strongly suggest the underlying cause? Your options are A. Serum sodium of 133 micol. B. Serum triglycerides of 1,480 mg/dl. C. Serum albumin of 3.1 g/dl. D. Serum potassium of 3.3 mqe. What's your answer? Commit to one before I continue. The correct answer is B. serum triglycerides of 1,480 barns in DL. B is correct because triglyceride levels above 1,000 elastase DL are an established trigger for acute pancreatitis, and the normal value is under 150 mdl. Lipase, acting on the excess triglyceride, generates free fatty acids that are directly toxic to pancreatic tissue. When gallstones and alcohol are both excluded, hypertriglyceridemia moves high on the list. A is wrong because mild hyponatremia is common in acutely ill patients with vomiting and fluid shifts. It reflects the illness rather than pointing to a specific cause. C is wrong because A, modestly low albumin, reflects inflammation, poor intake, or capillary leak. It is a nonspecific marker and does not identify an etiology. D is wrong because hypokalemia is a frequent consequence of vomiting and nasogastric suction in pancreatitis. It is a complication to correct rather than a clue to the cause. Cholesterol and triglycerides are usually blamed for slow arterial damage over decades, not sudden abdominal emergencies. But extreme triglyceride levels are the third leading cause of acute pancreatitis after gallstones and alcohol. Lipase, an enzyme that normally breaks down fat safely, becomes dangerous when overwhelmed with substrate. It splits the excess triglycerides into free fatty acids, and those fatty acids directly poison acinar cells and the capillary lining of the pancreas, triggering injury and premature enzyme activation. Normal fasting triglycerides sit below 150, concern begins above 500, and the recognized danger zone starts at 1,000, roughly 7 times normal. This level of severity typically appears in people with severe lipid disorders, poorly controlled diabetes, or a mix of genetics and heavy alcohol use. A lab quirk complicates diagnosis. Extreme lipemia can falsely lower amylase, so lipase becomes the more trustworthy test. Treatment also diverges from routine care, using insulin infusion to activate lipoprotein lipase and clear triglycerides, or plasmapheresis in severe cases, alongside long-term fibrates and lifestyle changes. When a stem carefully excludes gallstones and alcohol, it's steering you toward triglycerides, not the rarer metabolic twin, hypercalcemia. One triglyceride value can change the entire diagnostic trajectory. Question 13. A patient taking several chronic medications is diagnosed with acute pancreatitis, and the provider suspects a drug cause. Which medication on the patient's list should the nurse flag as the most likely culprit? Your options are A. Valproic acid for seizure prophylaxis, B. Levothyroxine for hypothyroidism, C. Metformin for type 2 diabetes, D. Atorvastatin for hyperlipidemia. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Valproic acid for seizure prophylaxis. A is correct because valproic acid is among the best documented drug causes of acute pancreatitis, along with thiazide diuretics, azathioprine, sulfonamides, and estrogen. When a drug is identified as the trigger, discontinuation is part of definitive management. Flagging the agent early prevents a recurrent episode after discharge. B is wrong because levothyroxine replaces a deficient thyroid hormone and has no established association with pancreatic inflammation. Stopping it would create a new problem without addressing the pancreatitis. C is wrong because metformin is not a recognized cause of pancreatitis, though it is often held in acutely ill patients for other reasons such as lactic acidosis risk. It does not belong on the list of pancreatitis-inducing drugs. D is wrong because statins treat the hyperlipidemia that can contribute to pancreatitis and are not themselves a common trigger. Withdrawing a statin would work against control of a genuine risk factor. When pancreatitis shows up without gallstones, alcohol, or high triglycerides, the medication list becomes the most important clue in the chart. Drug-induced pancreatitis is rare compared to biliary or alcoholic disease, but because it's completely preventable once recognized, it carries outsized clinical importance. A short list is worth memorizing: valproic acid, thiazide diuretics like hydrochlorothiazide, azathioprine and mercaptopurine, sulfonamide antibiotics, estrogen-containing preparations, and corticosteroids. Some of these drugs are directly toxic to acinar cells. Others trigger idiosyncratic hypersensitivity. And estrogens act indirectly by raising triglycerides high enough to precipitate pancreatitis on their own. Some cases appear within days to weeks, fitting a hypersensitivity pattern, while others emerge after years of stable use and become much easier to dismiss. A long duration of therapy does not exonerate a drug, and once it's identified, the action is simple: stop it, document it, and don't restart it later. The confusable topic is drug-induced liver injury, which shares the same reasoning but not the same organ. Acetaminophen, isoniazid, and amiodarone injure the liver, while valproic acid, thiazides, and azathioprine injure the pancreas. And valproic acid actually appears on both lists. The distinguishing feature is which lab value rises. Laplace points to the pancreas, transaminases point to the liver. Discipline cuts both ways. Levothyroxine, statins, and metformin are not pancreatitis culprits, and pulling them creates new problems instead of solving the real one. The nurse who correctly flags the true offending drug on admission has done more for that patient than most of the supportive care that follows. Question 14. A nurse enters the room of a patient admitted with acute pancreatitis and finds the patient curled onto one side with knees drawn towards the chest. The patient states this position helps the pain. How should the nurse interpret this finding? Your options are: A. It suggests the pain is largely anxiety-driven and will respond to reassurance. B. It indicates peritonitis has developed and the patient should be repositioned flat. C. It is a characteristic finding in pancreatitis, since the fetal position reduces tension on the inflamed retroperitoneal gland. D. It suggests the patient is developing a bowel obstruction rather than pancreatic inflammation. Which would you go with? Lock it in before the reveal. The correct answer is C. It is a characteristic finding in pancreatitis, since the fetal position reduces tension on the inflamed retroperitoneal gland. C is correct because pancreatic pain is classically relieved by curling into a knee-to-chest position or by sitting up and leaning forward, both of which reduce stretch on the inflamed retroperitoneal gland. The same pain worsens when the patient lies flat after eating and with alcohol. Recognizing the pattern supports the diagnosis and guides comfort measures. A is wrong because the pain of pancreatitis is severe, organic, and often requires intravenous opioids. Attributing a classic positional pattern to anxiety would delay appropriate analgesia. B is wrong because patients with peritonitis typically lie rigidly still and avoid any movement, and forcing a flat position would worsen pancreatic pain. Positioning the patient supine is the opposite of what helps here. D is wrong because bowel obstruction produces cramping, waves of pain, distension, and vomiting, and patients typically writhe rather than settle into one position. The described posture points toward pancreatic disease. Patients with acute pancreatitis describe their pain the same way again and again: boring, knife-like, penetrating, as if driven straight through the abdomen and out the back. That consistency is not coincidence. It reflects exact anatomy and it makes the pain history a genuine diagnostic tool. The pain sits epigastric or in the left upper quadrant and radiates straight through to the back, not around the flanks or up the shoulder. That's because the pancreas lies retroperitoneally, tucked behind the peritoneum and right in front of the vertebral column. So inflammation there is felt posteriorly. and unlike many abdominal pains, it stays steady rather than coming in waves. 3 factors reliably worsen the pain. Eating stimulates pancreatic secretion, raising pressure in the inflamed gland. Alcohol acts through direct toxicity to the acinar cells, and lying flat stretches the retroperitoneal tissue over the spine. Vomiting is nearly universal, and tellingly it brings no relief. Patients find relief curling into a fetal position or sitting up and leaning forward over a table, and refusing to leave that position is itself diagnostic information. This is where pancreatitis contrasts sharply with peritonitis. Peritonitis, patients lie rigidly still, while pancreatitis, patients move constantly searching for a relief. Hunched posture, back radiation, unrelieved vomiting, and a soft abdomen together point to pancreatitis before any lipase result comes back. Reading how a patient holds their body takes no equipment at all. Question 15. During an abdominal assessment on the second hospital day, a nurse caring for a patient with acute pancreatitis notes marked distension, absent bowel sounds in all 4 quadrants, and no passage of flatus. Which explanation is most likely? Your options are: A. Perforation of the pancreatic duct has released enzymes into the peritoneum. B. Retroperitoneal inflammation has produced a paralytic ileus. C. The patient has developed a mechanical small bowel obstruction from adhesions. D. Opioid analgesia has caused complete cessation of gastric acid secretion. Don't overthink it, which one feels right? The correct answer is B. Retroperitoneal inflammation has produced a paralytic ileus. B is correct because inflammation adjacent to the bowel temporarily paralyzes intestinal motility, producing a paralytic ileus with hyperactive or absent bowel sounds and distension. It is an expected finding in acute pancreatitis rather than a rare complication. Nasogastric decompression is indicated when distension, vomiting, or ileus is significant. Is wrong because ductal perforation with free enzymes in the peritoneum would produce a rigid, board-like abdomen with intense rebound tenderness and rapid deterioration. This patient's picture is distension without peritoneal signs. C is wrong because mechanical obstruction typically produces high-pitched, hyperactive bowel sounds proximal to the blockage before sounds diminish. It also requires an anatomic cause such as prior surgery, which is not described. D is wrong because opioids slow gut motility and can worsen an ileus, but they do not eliminate gastric acid secretion. The primary driver of the ileus here is the adjacent pancreatic inflammation. Silent bowel sounds across all 4 quadrants sound alarming, but in acute pancreatitis, this is often an expected finding, not a crisis. Understanding why prevents both panic and dangerous complacency. The pancreas sits directly against the retroperitoneal bowel, and inflammation there suppresses motility even though the bowel itself is structurally fine. Hypocalcemia and opioids deepen this paralysis, so gas and fluid build up, the abdomen distends, and sounds disappear. Nasogastric decompression is placed for intractable vomiting, significant distension, or a clinically apparent ileus, not for every patient with pancreatitis. Once placed, nursing priorities are verifying placement, maintaining patency, and tracking output for fluid balance. The key distinction is mechanical small bowel obstruction, which produces high-pitched, rushing sounds proximal to an anatomic blockage like adhesions or a hernia. Ileus is quiet from the start across all quadrants with no lesion to find, and that difference decides whether a patient needs surgery or simply time. Absent bowel sounds with a soft, improving abdomen is ileus resolving on schedule, but the same silence with severe pain and bloody diarrhea, or a rigid belly signals ischemia or perforation. Feed the gut early when possible, since enteral nutrition protects the intestinal barrier far better than bypassing it with parenteral feeding. Question 16. On the 4th hospital day, A nurse caring for a patient with acute pancreatitis notices a bluish-purple discoloration developing around the umbilicus. What does this finding indicate? Your options are A. Bruising from repeated subcutaneous heparin injections in the abdomen. B. Early jaundice from obstruction of the common bile duct. C. A superficial cellulitis developing at an old surgical scar. D. Cullen's sign indicating retroperitoneal hemorrhage and severe necrotizing pancreatitis. Got a guess? Lock it in. The correct answer is D. Cullen's sign indicating retroperitoneal hemorrhage and severe necrotizing pancreatitis. D is correct because Cullen's sign is periumbilical ecchymosis, produced when blood from a retroperitoneal hemorrhage tracks to the umbilical area. It marks hemorrhagic or necrotizing disease and demands immediate escalation of care. The nurse should notify the provider, anticipate contrast-enhanced CT, and trend hemoglobin and hematocrit. A is wrong because heparin injection bruises are small, discrete, and located at individual injection sites. They do not produce a confluent bluish discoloration centered on the umbilicus. B is wrong because jaundice produces a yellow discoloration best seen in the sclerae and skin generally, not a bluish-purple ring around the navel. Bile duct obstruction raises bilirubin rather than causing local bruising. C is wrong because cellulitis presents with warmth, redness, swelling, and tenderness rather than a bluish bruise pattern. The color and distribution here point clearly to retroperitoneal bleeding. A late sign isn't just a finding that shows up eventually. It's a finding that only appears after the disease process has already been running long enough to leave visible evidence, which means by the time you see it, it's already too late to serve as an early warning. Cullen's sign is bluish-purple discoloration around the umbilicus, and Gray-Turner's sign is ecchymosis along the flanks. Both come from blood that escaped digested vessels, pulled retroperitoneally, and migrated along fascial planes for days before reaching skin thin enough to show through. The correct response is escalation, not documentation and routine care. Notify the provider immediately. Anticipate a contrast-enhanced CT scan. Continue aggressive fluid resuscitation. Trend hemoglobin and hematocrit for a downward drift, and prepare for possible ICU transfer. Waiting for a bruise is poor surveillance because numerical trends move first. A hematocrit that falls after early hemoconcentration signals bleeding. A rising bun despite fluids predicts a worse course. Falling calcium signals ongoing fat necrosis, and rising temperature and white count signal necrosis or infection. Remember that these signs report on the retroperitoneal compartment holding the blood, not on which organ leaked it. In a ruptured aortic aneurysm with sudden back pain and hypertension, reading the bruise as pancreas-specific would delay a diagnosis measured in minutes. Question 17. A patient presents to the emergency department 5 days after the onset of severe epigastric pain radiating to the back. The serum amylase is within normal limits. Which laboratory value should the nurse expect to be most useful in confirming acute pancreatitis at this point? Your options are A. Serum lipase, which rises early and stays elevated for 8 to 14 days. B. Serum alkaline phosphatase, which is specific to pancreatic acinar injury. C. White blood cell count, which is diagnostic of pancreatic inflammation. D. Serum albumin, which falls in proportion to the degree of pancreatic necrosis. Which one is it? Pause the video if you need more time. The correct answer is A. Serum lipase, which rises early and stays elevated for 8 to 14 days. A is correct because lipase is both more specific to the pancreas than amylase and remains elevated far longer, typically 8 to 14 days. Amylase normalizes within 3 to 5 days. So a patient presenting late may have a normal amylase and a still diagnostic lipase. This is exactly the scenario in which lipase earns its reputation. B is wrong because alkaline phosphatase reflects biliary obstruction and bone turnover, not acinar cell injury. It helps point toward a gallstone cause but does not confirm pancreatitis. C is wrong because leukocytosis signals systemic inflammation from any source, including infection and tissue injury. It supports the clinical picture but is far too nonspecific to confirm a diagnosis. D is wrong because albumin falls with inflammation, capillary leak, and poor nutrition across many illnesses. It is a marker of overall illness rather than a diagnostic test for pancreatitis. Amylase and lipase test for the same disease, but they aren't redundant. They differ in two key ways: how long they stay elevated and how specific they are to the pancreas. Amylase spikes early and clears within 3 to 5 days, while lipase stays elevated for 8 to 14 days. A patient who waits 5 days before seeking care may show a normal amylase alongside a still diagnostic lipase. Specificity is the second difference. Amylase also comes from the salivary glands and rises with parotitis, bowel obstruction, mesenteric ischemia, and renal failure. So an elevated amylase doesn't confirm pancreatitis. Lipase is far more specific to pancreatic tissue, which is why many institutions order it alone. Here's the counterintuitive part. The size of the elevation carries no prognostic weight. A lipase of 2,400 isn't worse than 420. Severity is judged by organ dysfunction and lab trends instead, and in chronic pancreatitis, a normal lipase can mean tissue has already been destroyed, not that the patient is well. Use lipase for its duration and specificity, but judge severity by organ function, and never delay feeding just because a number hasn't normalized. Question 18. A patient is admitted with newly diagnosed acute pancreatitis. Which imaging study should the nurse expect to be ordered first? Your options are A. Magnetic resonance cholangiopancreatography to map the ductal anatomy. B. Contrast-enhanced computed tomography to grade the extent of necrosis. C. Abdominal ultrasound to evaluate for gallstones and biliary dilation. D. Plain abdominal radiograph to identify pancreatic calcifications. Take a second. Which answer would you pick? The correct answer is C. Abdominal ultrasound to evaluate for gallstones and biliary dilation. C is correct because ultrasound is the first-line study because gallstones are the most common cause and identifying them changes management. It is inexpensive, requires no contrast or radiation, and reliably shows stones and dilated bile ducts. Confirming a biliary cause sets up endoscopic retrograde cholangiopancreatography and eventual cholecystectomy. A is wrong because magnetic resonance cholangiopancreatography is reserved for patients who cannot receive CT contrast or who need detailed biliary imaging. It is a second-line study rather than the initial evaluation. B is wrong because contrast-enhanced CT is the gold standard for assessing the pancreas itself and is often deliberately delayed 48 to 72 hours, so necrosis has time to declare itself. It is not the first study on admission. D is wrong because plain films may show calcifications in chronic pancreatitis, but add little in an acute presentation. They cannot assess the gland or reliably detect gallstones. In acute pancreatitis, the first imaging study ordered is not even a picture of the pancreas. That surprises a lot of students, but it reflects exactly how good clinical reasoning works. Ultrasound is first line because gallstones are the most common cause of acute pancreatitis, and finding them changes the plan immediately. It's also inexpensive, portable, avoids radiation and contrast, can be repeated freely, and reliably detects stones and bile duct dilation. The problem is anatomy. The pancreas sits retroperitoneally, tucked behind the stomach and transverse colon, and bowel gas scatters sound waves. So ultrasound frequently cannot see the gland well, especially in the sickest, most distended patients. That's where contrast-enhanced CT comes in, the gold standard for the gland itself, revealing inflammation, fluid collections, and necrosis. It's typically delayed 48 to 72 hours. Because necrosis takes time to appear and an early scan can be falsely reassuring. Ultrasound answers why this happened. CT answers how bad it is. Ordering CT before ultrasound isn't just inefficient. It exposes a patient to radiation and contrast when a 10-minute bedside scan could have already answered the most urgent question: what caused this? Question 19. A patient admitted 36 hours ago with acute pancreatitis has worsening pain, a temperature of 101.8 degrees Fahrenheit, and a rising white blood cell count. The provider orders imaging. Which study is the gold standard for evaluating the pancreas itself in this situation? Your options are A. Abdominal ultrasound with Doppler, B. Contrast-enhanced computed tomography of the abdomen, C. Upright and supine abdominal radiographs, D. Endoscopic retrograde cholangiopancreatography. Before I reveal it, which one do you think is right? The correct answer is B. Contrast-enhanced computed tomography of the abdomen. B is correct because contrast-enhanced CT is the gold standard for visualizing the pancreas, identifying necrosis, fluid collections, pseudocysts and abscesses, and grading severity. Delaying it roughly 48 to 72 hours after onset improves its ability to demonstrate necrosis, which takes time to become visible. This patient's fever, rising white count, and worsening pain make necrosis the key question. A is wrong because ultrasound excels at finding gallstones, but is limited in imaging the pancreas itself, since overlying bowel gas obscures the retroperitoneum. It cannot reliably grade necrosis. C is wrong because plain films can show ileus patterns or calcifications, but provide no useful detail about pancreatic viability. They would not answer the clinical question here. D is wrong because endoscopic retrograde cholangiopancreatography is a therapeutic procedure for relieving biliary obstruction, and it can itself cause pancreatitis. It is not a diagnostic imaging study for pancreatic necrosis. Contrast-enhanced CT in acute pancreatitis is not an admission test. It is ordered when a patient stops improving, developing fever, a rising white count, and worsening pain days into hospitalization, and it exists to answer one question: is pancreatic tissue dying, and how much? IV contrast lights up any tissue that still has blood flow. Dead tissue has no perfusion, so it takes up no contrast and shows as a dark region against the bright viable gland. The scan is mapping blood flow, not photographing inflammation, and that is why a non-contrast scan cannot substitute. Necrosis doesn't appear the instant enzymes activate. Tissue needs roughly 48 to 72 hours to lose perfusion and declare itself. A scan done too early can look deceptively unremarkable, so delaying the study isn't a scheduling compromise. It's what makes a negative result trustworthy. MRCP steps in when iodinated contrast is contraindicated, in renal insufficiency or contrast allergy, imaging the ducts without the nephrotoxic risk, though it's slower and less available. Ultrasound comes first in the workup to find the cause, like gallstones, while CT comes later to find the consequence, necrosis and complications. The real judgment call is whether a finding will actually change management, weighing contrast's renal risk against the value of catching infected necrosis early. Get the sequence right: ultrasound for cause, CT for consequence, and each study answers the question it's actually built to answer. Question 20. A nurse is caring for two patients with acute pancreatitis. The first has a serum lipase of 2400 UL, normal vital signs, and no organ dysfunction. The second has a lipase of 420 UL, a rise in burn, a fall in calcium, and worsening oxygenation. Which conclusion should the nurse draw? Your options are: A. The first patient has more severe disease because the enzyme elevation is far greater. B. Both patients have equivalent disease severity since both lipase values exceed the diagnostic threshold. C. Severity cannot be assessed until 48 hours of enzyme trending are available. D. The second patient has more severe disease because severity is judged by organ dysfunction rather than by enzyme magnitude. What's your answer? Commit to one before I continue. The correct answer is D. The second patient has more severe disease because severity is judged by organ dysfunction rather than by enzyme magnitude. D is correct because the magnitude of amylase or lipase elevation does not correlate with the severity of pancreatitis. Severity is judged by clinical scoring systems and by evidence of organ dysfunction such as rising bun, falling calcium, and deteriorating oxygenation. The second patient is populating the criteria that predict a bad outcome. A is wrong because a very high lipase confirms the diagnosis but says nothing about prognosis. A patient can have a modestly elevated lipase with extensive necrosis or a very high value with mild disease. B is wrong because meeting the diagnostic threshold establishes that pancreatitis is present, not how severe it is. The two clinical pictures described here are far from equivalent. C is wrong because waiting 48 hours before recognizing severity would waste the window in which aggressive resuscitation and escalation matter most. Organ dysfunction is accessible at the bedside right now. Most patients with acute pancreatitis recover with fluids and time, but a minority progress to necrosis and organ failure. Sorting these two groups in the first 48 hours is exactly what severity scoring systems were built to do. Ranson's criteria use 11 parameters. 5 at admission form GA law and 6 more at 48 hours form C-HOPS. The more criteria a patient accumulates, the higher the predicted mortality. The structure of the score is itself instructive. Nearly every parameter reports on a process already at work in the disease. Falling calcium reflects fat saponification. A dropping hematocrit reflects hemorrhage. Low oxygen reflects lung injury. And rising bun with fluid sequestration reflects third spacing. The revised Atlanta classification sorts disease into mild, moderately severe with transient organ failure, and severe with organ failure persisting beyond 48 hours, which is its single strongest predictor of death. BSAP is a simpler bedside tool using BUN, mental status, SARS, age, and pleural effusion. Notice that nearly every value in all these scores, except age, is something a nurse directly measures or observes. The most important negative claim here is that amylase and lipase appear nowhere in Ranson's BSAP or Atlanta. A sky-high lipase only reflects how much enzyme leaked out, not how much tissue will die. So ranking patients by enzyme level is a trap. Question 21. A patient arrives in the emergency department with acute pancreatitis, a heart rate of 118, a blood pressure of 94/58, and a hematocrit of 54%. Which intervention should the nurse anticipate as the highest immediate priority? Your options are: A. Administering a proton pump inhibitor to reduce pancreatic stimulation. B. Obtaining a contrast-enhanced computed tomography scan of the abdomen. C. Beginning aggressive intravenous fluid resuscitation with an isotonic crystalloid. D. Starting prophylactic broad-spectrum intravenous antibiotics. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. beginning aggressive intravenous fluid resuscitation with an isotonic crystalloid. C is correct because massive third spacing leaves these patients profoundly volume depleted, and the elevated hematocrit is direct evidence of hemoconcentration. Early aggressive hydration, generally with lactated ringers, is one of the interventions most clearly linked to better outcomes. Adequacy is judged by a urine output of at least 0.12 methyl per hour, a falling heart rate, and a declining burn and hematocrit. A is wrong because proton pump inhibitors are used for acid suppression and stress ulcer prophylaxis and are a reasonable part of the regimen. They do nothing for the hypovolemia that is threatening perfusion right now. B is wrong because contrast-enhanced CT is valuable, but is typically delayed 48 to 72 hours, so necrosis becomes visible. Sending an unresuscitated hypotensive patient to radiology delays the intervention that matters. D is wrong because antibiotics are reserved for confirmed infected necrosis or another documented infection. Prophylactic use does not improve outcomes and promotes resistance. In acute pancreatitis, orders pile up fast, but only one intervention changes whether the kidneys survive the next 12 hours. Early, aggressive intravenous fluid resuscitation. No medication halts the pancreas from digesting itself in those first hours. The real threat is intravascular volume loss from capillary leak and a fast heart rate, low blood pressure, and rising hematocrit signal compensated shock, where kidneys fail quietly and quickly. Adequacy is judged by nursing endpoints. Urine output of at least 0.5 milliliter per kilogram per hour, a heart rate trending downward with a mean arterial pressure near 65, improving mental status, and falling hematocrit and burn. A burn that keeps climbing despite fluids is one of the strongest predictors of a severe course. Lactated ringers is generally preferred over normal saline, since large volume saline causes a hyperchloremic acidosis that may worsen trypsinogen activation. Still, either fluid beats inadequate resuscitation by a wide margin. Nurses titrate within a corridor. Under resuscitation shows up as oliguria, tachycardia, and rising hematocrit or burn, while over resuscitation floods the lungs, causing crackles, falling oxygen saturation, and rising respiratory rate. CT scans, antibiotics, and PPIs feel more sophisticated, but none of them restore circulating volume first. Question 22. A patient with moderately severe acute pancreatitis has been NPO for 3 days and remains unable to tolerate oral intake. The provider is considering nutritional support. Which approach should the nurse expect? Your options are A. Enteral feeding through a nasogastric or nasojejunal tube because using the gut preserves the intestinal barrier and lowers infection risk. B. Total parenteral nutrition, because any feeding into the gut will stimulate the pancreas and worsen the inflammation. C. Continued NPO status with intravenous fluids alone until serum lipase returns fully to normal. D. An immediate regular diet, since prolonged NPO status has no effect on pancreatic recovery. Which would you go with? Lock it in before the reveal. The correct answer is A. Enteral feeding through a nasogastric or nasojejunal tube, because using the gut preserves the intestinal barrier and lowers infection risk. A is correct because current practice favors early enteral nutrition, ideally within 24 to 72 hours in moderate to severe disease. Keeping the gut working maintains the intestinal barrier and reduces the translocation of bacteria that drives infected necrosis. Enteral feeding through a nasogastric or nasojejunal tube is preferred over parenteral nutrition whenever the gut can be used. B is wrong because total parenteral nutrition is a fallback for patients whose gut cannot be used, not the default. It carries higher rates of catheter infection and does not protect the intestinal barrier, C is wrong because waiting for lipase to normalize would starve the patient unnecessarily, since enzyme levels do not track recovery or severity. Prolonged NPO status without nutritional support worsens outcomes. D is wrong because a regular diet is advanced only as pain and nausea subside, beginning with clear liquids and moving to low fat. Jumping straight to a regular diet in an intolerant patient invites recurrent pain and vomiting. For decades, doctors kept pancreatitis patients nil by mouth for as long as possible, believing food would stimulate the pancreas and worsen injury. That reasoning felt intuitive, but practice has reversed, and understanding why reveals something deeper about how the gut protects the whole body. Nobody disputes the first few days. Patients are vomiting, in severe pain, and often have an ileus, so a nasogastric tube may be added for intractable vomiting or distension. The real question is what happens after that initial phase. The mucosal lining depends on nutrients passing through it, and without them, it atrophies within days. That thinned barrier lets gut bacteria translocate into the bloodstream, and next to necrotic pancreatic tissue. That is precisely how sterile necrosis becomes infected necrosis, the most dangerous complication in the disease. This mechanism reframes feeding as infection prevention, not just nutrition. So early enteral feeding within 24 to 72 hours is now preferred whenever the gut can be used. Parenteral nutrition bypasses the intestine entirely, allowing the very atrophy the strategy prevents, so it is a fallback, not a default. The pancreas is rested by avoiding oral intake early, but the patient is protected by feeding the gut as soon as it safely can be fed. Don't confuse this with true bowel rest in inflammatory bowel disease or obstruction, where prolonged emptying is actually the goal. Question 23. A patient with acute pancreatitis develops a temperature of 102.4 degrees Fahrenheit, a white blood cell count of 21,000 mmHg, hemodynamic instability, and CT evidence of infected pancreatic necrosis. The nurse is reviewing the orders. Which statement about antibiotic therapy is accurate in this situation? Your options are: A. Antibiotics should have been started prophylactically on admission to prevent this complication. B. Antibiotics are ineffective in pancreatitis at any stage because the process is chemical rather than infectious. C. Antibiotics should be withheld until necrosectomy has been performed. D. Antibiotics are now indicated because confirmed infected necrosis is one of the few clear indications in pancreatitis. Don't overthink it, which one feels right. The correct answer is D. Antibiotics are now indicated because confirmed infected necrosis is one of the few clear indications in pancreatitis. D is correct because antibiotics in acute pancreatitis are reserved for confirmed infected necrosis or another documented infection, and this patient meets that standard. Fever, marked leukocytosis, instability, and imaging evidence of infected necrosis together justify treatment. Infected necrosis is also the main trigger for drainage or debridement. A is wrong because prophylactic antibiotics in sterile pancreatitis do not reduce mortality or prevent infected necrosis. Routine use selects for resistant organisms and fungal superinfection. B is wrong because sterile pancreatitis is indeed a chemical inflammatory process, but necrotic tissue can become secondarily infected by bacteria. Once that happens, antibiotics are essential. C is wrong because necrosectomy is generally delayed as long as possible, ideally beyond 4 weeks, to let the necrosis wall off. Withholding antibiotics during that interval would leave an unstable septic patient untreated. There's a rule in pancreatitis that fights every clinical instinct. A patient can look completely septic without being infected. Understanding why requires separating two ideas that get tangled together constantly. Fever, tachycardia, a sky-high white count, and low blood pressure aren't necessarily bacteria at work. Cytokines released by dying pancreatic tissue trigger the exact same pathways, producing a sterile inflammatory state that antibiotics simply have nothing to act on. When prophylactic antibiotics were tested in sterile necrosis, they didn't lower mortality or prevent later infection. Instead, routine use bred resistant organisms and increased fungal superinfection, a harder problem than the one it was meant to prevent. Confirmed infected necrosis looks different: rising fever, a climbing white count, deterioration after a plateau, and positive cultures. On CT, gas within the necrotic collection is nearly definitive, since it signals gas-forming organisms, and this is what triggers both antibiotics and eventual drainage. Prophylaxis means treating a patient with no identified infection, hoping to prevent one, and that failed in sterile necrosis. Treatment means responding to a confirmed infection, whether it's infected necrosis or an unrelated line infection or pneumonia, and that remains standard care. Holding these apart is what lets you follow the guideline without feeling like you're withholding care. Question 24. A nurse caring for a patient with severe necrotizing pancreatitis taps the facial nerve just anterior to the ear and observes twitching of the facial muscles. Which nursing action is most appropriate? Your options are: A. Document the expected finding and continue routine care. B. Place the patient on a cardiac monitor and anticipate intravenous calcium gluconate. C. Withhold the next dose of intravenous opioid and reassess in 1 hour. D. Increase the intravenous fluid rate to correct the underlying electrolyte disturbance. Got a guess? Lock it in. The correct answer is B. Place the patient on a cardiac monitor and anticipate intravenous calcium gluconate. B is correct because a positive Chvostek sign indicates hypocalcemia, which in necrotizing pancreatitis reflects calcium consumed by fat saponification. Hypocalcemia prolongs the QT interval and can precipitate torsades de pointes, so cardiac monitoring is essential. Intravenous calcium gluconate replacement and seizure precautions are the anticipated interventions. A is wrong because a positive Chvostek sign is an abnormal finding, signaling neuromuscular irritability, not an expected part of pancreatitis. Documenting without acting misses a potentially lethal electrolyte problem. C is wrong because opioids do not cause facial twitching, and withholding analgesia would leave severe pancreatic pain untreated. The finding is metabolic, not pharmacologic. D is wrong because crystalloid infusion does not replace calcium in a meaningful way and could further dilute it. Specific calcium replacement is what this patient needs. A 2-second cheek tap requires no equipment and no waiting for results. Yet, in necrotizing pancreatitis, it can reveal an electrolyte disturbance capable of closing an airway or triggering a lethal arrhythmia. That's the power of Chvostek's and Trousseau's signs. Chvostek's sign is elicited by tapping the facial nerve near the jaw, causing visible facial twitching. Trousseau's sign is elicited by inflating a blood pressure cuff above systolic pressure, causing carpal spasm with a characteristic hand posture. Both reveal the same underlying physiology. Calcium normally raises the threshold nerves and muscles need to fire. When serum calcium drops, that stabilizing effect disappears, and membranes become hyperexcitable, firing spontaneously from something as trivial as a tap or a cuff's pressure. The mnemonic cat organizes the picture: convulsions from CNS irritability, arrhythmias alongside Chvostek's sign, tetany alongside Trousseau's sign, and spasms including laryngospasm. Laryngospasm can silently close an airway, and prolonged QT can trigger torsades de pointes. The two lethal reasons this finding demands escalation, not just documentation. In pancreatitis, calcium is consumed as fatty acids bind it in necrotic fat, making the level a severity marker for tissue death. After thyroid or parathyroid surgery, identical signs instead reflect lost parathyroid hormone, same bedside findings, entirely different trajectory. Question 25. A patient recovering from Gallstone pancreatitis asks why the surgeon has scheduled removal of the gallbladder when the pancreas is the organ that was inflamed. Which response by the nurse is most accurate? Your options are: A. Removing the gallbladder eliminates the source of the stones and prevents another episode of pancreatitis. B. The gallbladder is removed because it becomes infected in every case of pancreatitis. C. Removing the gallbladder restores the pancreas's ability to produce digestive enzymes. D. The gallbladder is removed so that the pancreatic duct can be surgically widened at the same time. Which one is it? Pause the video if you need more time. The correct answer is A. Removing the gallbladder eliminates the source of the stones and prevents another episode of pancreatitis. A is correct because identifying and eliminating the cause is part of definitive management, and for biliary pancreatitis, that means removing the organ that produces the stones. Cholecystectomy is often performed during the same hospitalization once mild disease has resolved. Without it, another stone can impact at the ampulla and produce a repeat attack. B is wrong because gallbladder infection, or cholecystitis, is a separate condition that does not accompany every case of pancreatitis. The rationale for surgery is stone prevention, not infection. C is wrong because the pancreas regains enzyme production on its own as inflammation resolves in acute disease. Cholecystectomy has no effect on atenal cell function. D is wrong because ductal widening is not a routine part of cholecystectomy. When the bile duct is obstructed, the stone is removed and the sphincter of Oddi may be cut during endoscopic retrograde cholangiopancreatography, which is a separate procedure. A patient can recover fully from Gallstone pancreatitis and still carry the exact anatomic setup that caused it. About a third of untreated patients come back with another attack, so real management means fixing the cause, not just the episode. Definitive biliary management splits into two procedures with different indications and timelines. ERCP clears the blockage that exists right now, while cholecystectomy prevents the blockage that would otherwise happen next, and neither one substitutes for the other. ERCP works by passing a duodenoscope to the ampulla of Vater, cannulating the ducts, and extracting the impacted stone, often after a sphincterotomy that widens the outlet. But cannulating the ampulla and injecting contrast can itself irritate the pancreatic duct. So this urgent option is reserved narrowly for cholangitis or persistent obstruction, not used on every patient. Patients often ask why the uninflamed gallbladder is removed while the inflamed pancreas is left alone. The answer is that the pancreas heals on its own, but the gallbladder never stops making stones, so removing it is framed as prevention rather than treatment. Necrosectomy and pseudocyst drainage are easy to confuse with this plan, but they respond to what the disease did. Debriding dead tissue or draining a fluid collection weeks later. Cholecystectomy alone responds to what caused it in the first place. Question 26. A patient with a 15-year history of heavy alcohol use is diagnosed with chronic pancreatitis. The patient asks whether the pancreas will heal the way it did after a previous acute attack. Which response reflects an accurate understanding of the condition? Your options are: A. The gland fully regenerates once alcohol is stopped, typically within 6 months. B. The gland heals but loses only its endocrine function, so enzyme production remains normal. C. The damage is progressive and irreversible, with functioning tissue replaced by fibrosis and calcification. D. The damage reverses only if pancreatic enzyme replacement is started within the first year. Take a second, which answer would you pick? The correct answer is C. The damage is progressive and irreversible, with functioning tissue replaced by fibrosis and calcification. C is correct because chronic pancreatitis is defined by progressive, permanent destruction in which glandular tissue is replaced by scar and calcium deposits, unlike an acute episode from which the gland can recover. This represents structural loss that does not reverse. Chronic alcohol use is the most common cause in adults. A is wrong because stopping alcohol holds further destruction and is the single most important intervention, but it cannot rebuild fibrotic tissue. The benefit is preservation of what remains, not regeneration. B is wrong because both functions fail over time. Exocrine failure produces malabsorption and steatorrhea, and endocrine failure produces diabetes. D is wrong because pancreatic enzyme replacement treats the consequences of exocrine insufficiency by supplying enzymes the gland can no longer make. It does not restore pancreatic tissue, regardless of when it is started. Will the pancreas heal the way it did after that acute attack? The honest answer is no, and understanding why reveals the entire distinction between these two diseases. Chronic pancreatitis is progressive, irreversible destruction. Repeated inflammatory episodes activate stellate cells that lay down collagen. Ducts get blocked by protein plugs and stones, and the end result is a small, hard, scarred gland that can no longer digest food or regulate blood sugar. Acute pancreatitis is in principle reversible. Surviving tissue recovers. A patient can survive a devastating single attack with a functionally intact pancreas, while another accumulates years of mild, barely noticed inflammation and ends up with almost nothing left. It's duration and repetition, not intensity, that determines which disease develops. The clinical triad is abdominal pain, malabsorption, and diabetes. Oddly, pain can diminish in late burned-out disease, not because the patient is improving, but because there's simply less tissue left to hurt. Stopping alcohol and smoking won't regenerate pancreatic tissue, but they hold further destruction, which in a disease of cumulative loss is an enormous benefit. The goal is preserving what remains, not recovering what's already gone. Question 27. A patient with long-standing chronic pancreatitis presents with epigastric pain and weight loss. The serum amylase and lipase are both within normal limits. How should the nurse interpret these results? Your options are: A. Normal enzyme levels rule out pancreatic disease and point toward a gastric ulcer. B. Normal enzyme levels are expected because so little functioning acinar tissue remains to release enzymes. C. Normal enzyme levels indicate the chronic pancreatitis has resolved and the gland has healed. D. Normal enzyme levels suggest the specimen was drawn too early and should be repeated in 4 hours. Before I reveal it, which one do you think is right? The correct answer is B. Normal enzyme levels are expected because so little functioning acinar tissue remains to release enzymes. B is correct because amylase and lipase are released by injured acinar cells, and in advanced chronic pancreatitis, most of those cells have already been destroyed and replaced by fibrosis. There is simply not enough enzyme-producing tissue left to generate a high serum level. This is a sharp and frequently tested contrast with acute pancreatitis, where levels exceed 3 times normal. A is wrong because normal enzymes cannot exclude chronic pancreatic disease, and the clinical picture of pain with weight loss fits chronic pancreatitis well. Anchoring on a gastric ulcer would miss the diagnosis. C is wrong because chronic pancreatitis does not resolve, and the ongoing pain and weight loss indicate active disease. Falling enzyme levels reflect tissue loss rather than recovery. D is wrong because the timing rule about drawing levels applies to acute presentations, and repeating the test would not change the picture. Diagnosis here rests on imaging and functional testing such as fecal elastase. A patient with 15 years of pancreatic disease has epigastric pain and weight loss, but normal amylase and lipase. In acute pancreatitis, these enzymes are the diagnostic backbone, so it seems like normal values should rule out pancreatic disease. They don't, and understanding why reveals something elegant about what lab values actually measure. Amylase and lipase rise only when acanine cells exist in quantity and get injured. In acute pancreatitis, both conditions hold, so enzymes spike. In advanced chronic pancreatitis, fibrosis has already replaced the acinar tissue, so there's nothing left to release, no matter how sick the patient is. Reading normal enzymes as reassurance inverts their true meaning. A clinician who pivots the workup toward gastric ulcer because the lipase is normal has been misled by a value that was actually confirming chronic pancreatitis from the opposite direction. Diagnosis rests on structure and function, not serum enzymes. CT and MRCP show ductal dilation, atrophy, and calcifications, while endoscopic ultrasound catches early changes. Fecal elastase 1, a simple stool test, directly measures exocrine function since elastase survives transit intact. The confusable case is late acute pancreatitis, where amylase normalizes by day 3 to 5, but lipase stays elevated 8 to 14 days. Chronic disease shows both enzymes flat against a background of years-long symptoms and structural change on imaging. Duration of symptoms sorts these two apart most reliably. Question 28. A patient with chronic pancreatitis reports bulky, greasy, foul-smelling stools that float in the toilet bowl. Which underlying problem does this finding indicate? Your options are A. Obstruction of the common bile duct preventing bile from reaching the intestine. B. Bacterial overgrowth in the small intestine following prolonged antibiotic therapy. C. Loss of endocrine function with resulting pancreatogenic diabetes. D. Exocrine pancreatic insufficiency with inadequate lipase reaching the intestine. What's your answer? Commit to one before I continue. The correct answer is D. Exocrine pancreatic insufficiency with inadequate lipase reaching the intestine. D is correct because steatorrhea is the most characteristic sign of exocrine pancreatic insufficiency and reflects fat that was never digested. It becomes clinically apparent once enzyme output falls below roughly 10% of normal. A low fecal elastase 1 level confirms the functional deficit, and pancreatic enzyme replacement is the treatment. A is wrong because biliary obstruction impairs fat emulsification and does produce pale stools, but it also produces jaundice, dark urine, and a rise in bilirubin. None of that is described here. B is wrong because bacterial overgrowth causes bloating, diarrhea, and malabsorption, but is not the expected explanation in a patient with known chronic pancreatitis. The pancreatic cause is far more likely and is directly testable. C is wrong because endocrine failure produces hyperglycemia and eventually insulin-dependent diabetes. It does not cause fat in the stool, which is purely an exocrine problem. Bulky, greasy, foul-smelling, floating stools are specific enough to be diagnostic on their own. This is steatorrhea, undigested fat passing through into the stool, and the most characteristic sign of exocrine pancreatic insufficiency. The mechanism is a shortage of lipase. Normally, pancreatic lipase splits dietary triglyceride into fatty acids and monoglycerides so it can be absorbed, but when fibrosis destroys enough acinar tissue, fat passes through undigested and ferments in the colon, producing the floating, greasy stool. Steatorrhea appears late because the pancreas has enormous functional reserve. Enzyme output must fall below roughly 10% of normal before insufficiency becomes clinically apparent. So by the time greasy stools show up, destruction is already far advanced. Lipase fails first among the enzymes, so fat malabsorption dominates, and because fat is the most calorie-dense nutrient, weight loss follows quickly. 3 contributors work together: malabsorption, reduced intake from pain, and the metabolic effects of diabetes. Fat malabsorption also drags down vitamins A, D, E, and K, causing bleeding, bone disease, and night blindness. Biliary obstruction mimics this picture, but announces itself with jaundice, dark urine, and rising bilirubin. Pale stools with jaundice point to the bile duct. Pale, greasy stools without jaundice in a damaged pancreas point straight to lipase. Question 29. A nurse is teaching a patient newly prescribed pancreas for chronic pancreatitis. Which instruction is most important to include? Your options are: A. Take the capsules with every meal and every snack, and swallow them whole rather than crushing or chewing them. B. Take the capsules on an empty stomach at least 1 hour before meals to maximize absorption. C. Take 1 capsule each morning since the enzymes remain active for a full 24 hours. D. Chew the capsules thoroughly so the enzymes begin working in the mouth. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Take the capsules with every meal and every snack, and swallow them whole rather than crushing or chewing them. A is correct because replacement enzymes only work if they are present in the intestine at the same time as food, which is why every meal and every snack requires a dose. The enteric coating protects the enzymes from stomach acid, so capsules must be swallowed intact. If a patient cannot swallow, the microspheres may be sprinkled on a small amount of acidic soft food and taken immediately without chewing. B is wrong because taking the dose separately from food defeats the purpose, since the enzymes would pass through before the meal arrives. Steatorrhea would continue despite adherence. C is wrong because these enzymes act only during the digestive window of the meal they accompany and are not long-acting. A single daily capsule would leave most meals undigested. D is wrong because chewing destroys the enteric coating and exposes the enzymes to gastric acid, inactivating them. Holding the beads in the mouth also irritates the oral mucosa. Pancreas almost always works pharmacologically. When it fails, the cause is usually how the patient takes it, not the dose itself. The drug contains lipase, amylase, and protease from porcine pancreas, dosed in lipase units because lipase deficiency drives the clinical problem. Brands like Creon, Pancreas, and Zenpep replace enzyme output, but they don't repair the gland itself. The enteric coating exists to shield enzymes from gastric acid until they reach the duodenum. Crushing or chewing destroys that protection, which is why capsules must be swallowed whole or opened only onto acidic soft food like applesauce. Enzymes only work when present in the gut with food, so every meal and snack needs a dose. And because a damaged pancreas also makes less bicarbonate, a co-prescribed proton pump inhibitor protects enzymes from acid that would otherwise inactivate them in the duodenum. Pancreas and insulin are often confused, but they address opposite functions of the same failing gland. One restores digestion, the other restores blood glucose control, with fat-soluble vitamins covering the downstream deficiency. Question 30. A patient with advanced chronic pancreatitis has developed diabetes and is starting insulin. Which additional teaching point is most important for this specific type of diabetes? Your options are: A. Oral metformin should be substituted for insulin once blood glucose stabilizes. B. Blood glucose targets should be set unusually low since this form of diabetes rarely causes hypoglycemia. Sir, the patient is at increased risk for hypoglycemia because both insulin and glucagon production are lost. D. Fat-soluble vitamin supplements should be discontinued once insulin therapy begins. Which would you go with? Lock it in before the reveal. The correct answer is C. The patient is at increased risk for hypoglycemia because both insulin and glucagon production are lost. C is correct because pancreatogenic diabetes destroys the alpha cells that make glucagon, along with the beta cells that make insulin. Without glucagon, the body loses its main counter-regulatory defense against a falling blood sugar, producing brittle swings and dangerous lows. For that reason, glucose targets in these patients are often kept slightly higher than usual. A is wrong because pancreatogenic diabetes reflects an absolute loss of insulin-producing tissue and typically requires insulin permanently. Metformin works by reducing hepatic glucose output and improving sensitivity, which does not replace absent insulin. B is wrong because the risk profile is the reverse of what this option states, since these patients are unusually prone to hypoglycemia. Aggressively tight targets would be hazardous. D is wrong because fat-soluble vitamin supplementation addresses exocrine failure and fat malabsorption, which insulin does not touch. Vitamins A, D, E, and K remain necessary alongside enzyme replacement. Most diabetes management assumes a working counter-regulatory system. When blood sugar drops too low, glucagon rescues it. Pancreatogenic diabetes, or type 3C, removes that safety net entirely, and understanding why changes everything about how it must be treated. Chronic pancreatitis destroys the pancreas indiscriminately. Beta cells that make insulin are lost, causing diabetes, but alpha cells that make glucagon are destroyed right alongside them, leaving the patient with neither hormone. Glucagon normally signals the liver to release glucose within minutes of a low. Without it, too much insulin, a skipped meal, or unexpected exercise sends blood sugar swinging with nothing to stop the fall, which is why these patients are called truly brittle. The key confusion is with type 1 diabetes. Type 1 destroys beta cells selectively through autoimmune attack, sparing alpha cells, so some glucagon response survives. Pancreatogenic diabetes destroys the whole islet, leaving no glucagon rescue at all. Because there's no glucagon to catch a low, glucose targets are deliberately kept looser, insulin remains mandatory, and enzyme replacement helps by making carbohydrate absorption more predictable. Pushing for tight normalization here applies the wrong diseases rules. Question 31. A 7-year-old man undergoes abdominal imaging for an unrelated complaint, and the radiologist reports that the abdominal aorta measures 3.4 cm below the renal arteries. How should the nurse interpret this measurement? Your options are A normal adult aortic diameter that requires no further attention. B, an abdominal aortic aneurysm, since the vessel exceeds 3 cm and warrants surveillance. C, an aortic dissection, because dilation above 3 cm indicates a tear in the intimal layer. D, a measurement error, since aneurysms form only above the renal arteries. Don't overthink it. Which one feels right? The correct answer is B, an abdominal aortic aneurysm, since the vessel exceeds 3 cm and warrants surveillance. B is correct because the normal adult abdominal aorta measures roughly 2 cm, and dilation to 3 cm or greater meets the definition of an aneurysm. That threshold represents an enlargement of at least 50% over expected size. A newly identified aneurysm of this size enters a surveillance program with risk factor modification rather than immediate surgery. A is wrong because a 3.4 cm aorta is well beyond normal and carries a defined natural history of gradual expansion. Ignoring it forfeits the entire rationale for surveillance and elective repair. C is wrong because dissection is a tear that splits the layers of the wall and creates a false channel, and it is diagnosed by imaging appearance rather than by diameter alone. Dilation and dissection are distinct entities that can coexist but are not the same thing. D is wrong because the great majority of abdominal aortic aneurysms form below the renal arteries in the infrarenal segment. This location is typical, not an error. Most abdominal aortic aneurysms are found by accident on a scan ordered for something else entirely. That's because this disease has a defining feature. It causes no symptoms at all until it is large or until it ruptures. The definition itself is purely a measurement. A normal abdominal aorta runs about 2 centimeters across, and a permanent dilation to 3 centimeters or more, at least 50% larger than expected, meets the definition of an aneurysm. Location is just as consistent as the definition. The abdominal aorta branches into the celiac trunk, the superior mesenteric artery, the renal arteries, and the inferior mesenteric artery, and most aneurysms form below the renal arteries in the infrarenal segment, which is fortunate because repair there spares the kidneys. The epidemiology points at a very specific group: men, roughly 4 times as often as women, with risk climbing sharply after age 65, and smoking, hypertension, atherosclerosis, and family history loading the dice further. That type profile is exactly why targeted screening works. An intact aneurysm feels like nothing, but a ruptured one kills 80 to 90% of patients, often before they reach a hospital, since symptoms never warn you in time. The only strategy is finding it early through screening and repairing it selectively on our own terms. Question 32. A nurse is explaining to a patient why a 5.1 cm aneurysm carries a much higher rupture risk than a 3.5 cm aneurysm at the same blood pressure. Which principle underlies this difference? Your options are: A. Larger aneurysms contain more mural thrombus, which erodes the wall chemically. B. Larger aneurysms receive a higher volume of blood per cardiac cycle, raising pressure inside them. C. Larger aneurysms have thicker walls that lose the ability to transmit pulsations. D. By the law of Laplace, wall tension rises in proportion to the radius, so a larger radius produces greater tension on an already weakened wall. Got a guess? Lock it in. The correct answer is D. By the law of Laplace, wall tension rises in proportion to the radius, so a larger radius produces greater tension on an already weakened wall. D is correct because the law of Laplace states that wall tension equals pressure multiplied by radius. As the aneurysm widens, tension climbs even if blood pressure is unchanged, and the higher tension drives further dilation in a self-reinforcing cycle. This is precisely why larger aneurysms expand faster and rupture more often, and why 5.5 cm is the usual repair threshold. A is wrong because mural thrombus does line many aneurysm sacs and can embolize, but it is not the reason rupture risk scales with size. The size relationship is a matter of physics rather than chemistry. B is wrong because pressure within the aorta is systemic blood pressure and does not rise simply because the vessel is wider. Radius, not pressure, is the variable that changes as the aneurysm grows. C is wrong because aneurysm walls become thinner and weaker as elastin and collagen degrade, not thicker. Loss of wall integrity is the entire problem. Wall tension equals pressure multiplied by radius. This single physics equation, the law of Laplace, explains more about abdominal aortic aneurysms than any fact of pathology alone. Picture the aortic wall like a balloon that has already lost elastin and collagen. If the radius doubles while pressure stays constant, tension on that weakened wall doubles as well, causing further dilation, more tension, and more dilation. The process feeds itself, making aneurysm growth non-linear rather than steady. The tunica media loses its structural elastin and collagen, so higher tension acts on an already weaker wall. This creates a feedback loop between radius and tension that drives small aneurysms to grow slowly, while large ones grow faster and rupture disproportionately more often. The equation identifies exactly two variables clinicians can act on. Pressure is modifiable, targeted with beta blockers and ACE inhibitors toward a systolic goal below 130, while radius is measurable and tracked through surveillance ultrasound at set intervals. Pressure inside the sac stays at systemic levels and does not rise simply because the vessel widened. It is radius that changes and drives danger. Holding on to the equation itself, rather than a vague sense that bigger is worse, is what reveals that distractor. Question 33. A patient with a newly diagnosed abdominal aortic aneurysm asks what has actually gone wrong with the blood vessel. Which explanation is most accurate? Your options are: plaque has completely occluded the vessel lumen, forcing blood to pool behind the blockage. B. The innermost endothelial lining has separated and folded outward into a pouch. C. Enzymes have degraded the elastin and collagen of the tunica media, so the wall thins and can no longer contain arterial pressure. D. Blood has escaped through a hole in the wall and is being contained by surrounding tissue. Which one is it? Pause the video if you need more time. The correct answer is C. Enzymes have degraded the elastin and collagen of the tunica media, so the wall thins and can no longer contain arterial pressure. C is correct because the fundamental lesion of an aneurysm is structural failure of the tunica media, the elastin-rich and collagen-rich middle layer that gives the aorta its strength and recoil. Hypertension, atherosclerosis, and smoking activate matrix metalloproteinases that break those proteins down faster than the body replaces them. Once the media thins, dilation begins. A is wrong because complete occlusion describes an occlusive arterial disease process, which produces ischemia distal to the blockage rather than dilation. An aneurysm is a widening, not a narrowing. B is wrong because the intima is a single layer of endothelial cells and is not what fails structurally in aneurysm formation. Intimal damage is where atherosclerosis begins, but the media is where the aneurysm forms. D is wrong because that description defines a false aneurysm or pseudoaneurysm, which is a contained rupture rather than a true dilation. True aneurysms involve stretching of all three intact layers. An artery is a three-layer composite structure, and each layer does a specific job. Once you understand that architecture, aneurysm, dissection, atherosclerosis, and pseudoaneurysm stop being four memorized terms and become four predictable consequences of damage to identifiable tissue. The tunica intima is a smooth endothelial lining in direct contact with blood, and injury here is where atherosclerosis begins and where dissection starts. The tunica media, built from smooth muscle elastin and collagen, gives the vessel its strength and recoil, and its degradation is the fundamental lesion of aneurysm. The tunica adventitia is tough outer connective tissue, carrying the vasa vasorum that feeds the thick wall itself and containing blood in a pseudoaneurysm. The degradation itself is enzymatic. Chronic stress from hypertension, smoking, and atherosclerotic inflammation activates matrix metalloproteinases, enzymes that break down elastin and collagen faster than the body can replace them. So the wall thins and loses its ability to recoil, and dilation begins. Atherosclerosis begins at the intima and narrows the vessel, causing downstream ischemia. Aneurysm reflects failure of the media and produces widening that risks rupture. Dissection starts as an intimal tear that splits the media into a false channel, and pseudoaneurysm is a hole through all layers with blood contained outside the vessel. An aneurysm is not stretching of intact material that could recover if pressure dropped. The structural scaffolding has been enzymatically dismantled and is not coming back, which is why treatment aims to slow progression, and why definitive fixes are mechanical, not medical. Question 34. A patient develops a pulsating tender mass at the right groin 2 days after cardiac catheterization. Imaging shows blood escaping through a defect in the femoral artery wall and being contained by surrounding tissue. Which term describes this finding? Your options are diffuse aneurysm, also called a pseudoaneurysm. B. Fusiform true aneurysm. C. Saccular true aneurysm. D. Aortic dissection. Take a second. Which answer would you pick? The correct answer is A. False aneurysm, also called a pseudoaneurysm. A is correct because a pseudoaneurysm is not a true dilation of the vessel wall. It is a contained rupture in which blood exits through a hole and is held in by adventitia or surrounding tissue, forming a pulsating hematoma that still communicates with the artery. Arterial puncture during catheterization is one of the classic causes, along with trauma and leaking graft anastomoses. B is wrong because a fusiform aneurysm is a spindle-shaped dilation involving the full circumference of the vessel, with all 3 layers intact but stretched. There is no wall defect in a true aneurysm. C is wrong because a saccular aneurysm is a one-sided outpouching connected by a neck, but it too involves intact stretched layers. The described hole in the wall rules out a true aneurysm of either shape. D is wrong because dissection occurs when blood tears into the layers of the wall through an intimal tear and creates a false channel within the wall. Here the blood has exited the vessel entirely and is contained outside it. A pulsating groin mass after a cardiac catheterization is not a typical aneurysm at all. It is a pseudoaneurysm, a fundamentally different lesion, and understanding how it differs from a true aneurysm explains why it behaves so dangerously. A true aneurysm is a dilation where the intima, media, and adventitia all remain intact and continuous, just thinner and weaker than normal. Blood never leaves the vessel. The atherosclerotic abdominal aortic aneurysm is the classic example, and its danger is that the stretched wall eventually fails. In a pseudoaneurysm, blood escapes through an actual hole in the wall and is held only by surrounding tissue, forming a pulsating hematoma still connected to the artery through that defect. The blood being outside the vessel, rather than inside a stretched but intact wall, is the essential distinction. Because its containment is just fragile tissue never built for the job, a pseudoaneurysm can expand, compress nearby nerves and veins, become infected, or rupture with little warning. Its causes are mechanical rather than degenerative: arterial puncture, catheterization or line placement, penetrating or blunt trauma, and leaking anastomoses at a graft site. Shape is a separate classification for true aneurysms. Fusiform is a uniform spindle-shaped dilation, while saccular is a one-sided outpouching linked by a neck. The mycotic aneurysm, despite its name, is caused by bacterial rather than fungal infection, producing an aggressive saccular outpouching that needs antibiotics plus surgery. Question 35. A nurse is counseling 4 patients about reducing their risk of abdominal aortic aneurysm expansion. Which modifiable factor should receive the greatest emphasis? Your options are A. Reducing dietary sodium to below 2 grams daily. B. Increasing weekly aerobic exercise to 150 minutes. C. Beginning a daily low-dose aspirin. D. Complete cessation of cigarette smoking. Before I reveal it, which one do you think is right? The correct answer is D. Complete cessation of cigarette smoking. D is correct because smoking is the single strongest modifiable risk factor for abdominal aortic aneurysm and the most important intervention for slowing growth. It directly weakens the arterial wall, promotes atherosclerosis, and accelerates expansion. Its association with aneurysm formation is stronger than with almost any other cardiovascular disease. A is wrong because sodium restriction supports blood pressure control, which does matter through the pressure term in the law of Laplace. It is a supporting measure rather than the dominant one. B is wrong because regular exercise improves overall cardiovascular health and is generally encouraged. It has no comparable effect on the rate of aneurysm growth. C is wrong because antiplatelet therapy addresses the coexisting coronary and peripheral arterial disease common in these patients. It does not slow aneurysm expansion. For most diseases, risk factors carry roughly equal weight. Abdominal aortic aneurysm breaks that pattern. Smoking towers above every other modifiable risk factor, more strongly than it links to almost any other cardiovascular disease. The mechanism is direct. Tobacco smoke promotes atherosclerosis that damages the intima, ramps up enzymes that chew through elastin and collagen in the media, and nicotine adds vasoconstriction and pressure on top. Together, this accelerates destruction of exactly the layer that keeps the wall from dilating. Smoking cessation measurably slows expansion rate, changing how many years pass before repair is needed. Other modifiable factors matter but rank lower. Hypertension control. Statins for hyperlipidemia and aspirin, which addresses cardiovascular risk rather than the aneurysm itself. Non-modifiable factors instead define who gets screened. Male sex, advanced age past 65, a first-degree relative with an aneurysm, and connective tissue disorders like Marfan or Ehlers-Danlos syndrome, which weaken the media and cause aneurysms much earlier in life. No drug shrinks an aneurysm, so below the repair threshold, risk factor modification is the treatment, not a backup plan. Smoking cessation is the single most powerful tool for slowing expansion and delaying or avoiding surgery. Question 36. A 68-year-old man with a 40-pack-year smoking history and no abdominal complaints comes to a primary care clinic for a routine visit. Which screening measure should the nurse anticipate? Your options are an annual computed tomography angiography of the abdomen and pelvis. B. A one-time abdominal ultrasound to screen for abdominal aortic aneurysm. C. Serial D-dimer testing every 6 months. D. Deep palpation of the abdomen at every clinic visit to detect a pulsatile mass. What's your answer? Commit to one before I continue. The correct answer is B. A one-time abdominal ultrasound to screen for abdominal aortic aneurysm. B is correct because the U.S. Preventive Services Task Force recommends a one-time screening abdominal ultrasound for men aged 65 to 75 who have ever smoked. And this patient fits that description exactly. Ultrasound is inexpensive, non-invasive, free of radiation and contrast, and accurate for measuring aortic diameter. Screening exists because these aneurysms are silent until they rupture. A is wrong because computed tomography angiography is the gold standard for surgical planning, not for screening. Annual CT would expose the patient to unnecessary radiation and contrast. C is wrong because D-dimer may be elevated when thrombus has formed within an aneurysm sac, but it is far too nonspecific to screen with. A normal or abnormal value would not establish or exclude an aneurysm. D is wrong because palpation is insensitive, particularly in patients with larger body habitus, and vigorous repeated palpation of a known aneurysm is discouraged. It is no substitute for imaging. Screening programs follow a strict logic, and abdominal aortic aneurysm satisfies nearly every part of it. It's common in an identifiable group, silent until lethal, detectable by a safe, cheap test, and treatable when caught early. The USPSTF recommends a one-time screening ultrasound for men 65 to 75 who have ever smoked. Every word matters. Men. Because of the 4-to-1 sex ratio, the age range, because risk climbs after 65 while repair benefit fades in the very elderly. Ever smoked? Because vessel damage outlasts quitting. And one time, because a normal aorta rarely changes later. Ultrasound wins on every practical axis. Inexpensive, widely available, no contrast, no radiation, and accurate for measuring diameter. Physical exam is a poor substitute, since a pulsatile mass is easy to miss and a normal exam offers no reassurance. CT angiography and D-dimer belong to later stages. Surgical planning or diagnosis, not screening. Once found, an aneurysm moves from screening to surveillance based on size. Small ones, 3 to 4 centimeters, are rechecked less often, while moderate ones, 4 to 5 centimeters, are followed every 6 to 12 months, watching both diameter and growth rate. Family members of an affected patient carry elevated risk too, so encouraging their screening is part of good discharge teaching. Remember the pattern: screen with ultrasound, survey by size, and reserve CT and repair for later in the pathway. Question 37. During an abdominal assessment, a nurse palpates a pulsating mass just above the umbilicus and auscultates a whooshing sound over the area. Which action should the nurse take next? Your options are: A. Palpate deeply and repeatedly to estimate the size and borders of the mass. B. Place the patient in a knee-to-chest position to relieve pressure on the vessel. C. Stop palpating, notify the provider, and prepare for diagnostic imaging. D. Apply firm continuous pressure over the mass to control potential bleeding. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Stop palpating, notify the provider, and prepare for diagnostic imaging. C is correct because a pulsatile abdominal mass with a systolic bruit is the classic physical finding of an abdominal aortic aneurysm. Deep, forceful, or repeated palpation carries a theoretical risk of precipitating rupture and adds nothing once the finding is documented. The appropriate next step is provider notification and imaging, usually ultrasound. A is wrong because repeated aggressive palpation is exactly what should be avoided in a suspected aneurysm. Imaging measures size accurately and safely. B is wrong because the knee-to-chest position relieves pancreatic pain and has no role in aneurysm care. It would neither reduce wall tension nor improve the situation. D is wrong because applying pressure over an intact aneurysm serves no purpose and could be harmful. There is no external bleeding to control. Abdominal aortic aneurysm is one of the rare exams with an explicit safety warning attached. Deep, forceful, or repeated palpation is discouraged because pressure on a weakened vessel wall carries a theoretical risk of rupture. And once an aneurysm is documented, imaging tells you more safely. The classic findings are a pulsatile midline mass above the umbilicus that expands laterally with each heartbeat, sometimes paired with a systolic bruit. The key distinction from a normal thin patient pulsation is that direction. A true aneurysm pushes outward on both sides, while a normal aorta only transmits a pulse upward. Presentation sorts into 3 phases. Asymptomatic is most common, where screening and incidental discovery operate. Symptomatic means new steady abdominal, back or flank pain, signaling expansion and itself an indication for repair. Ruptured is the emergency, sudden tearing pain, hypotension, tachycardia and syncope. Sensitivity is the weak point. Smaller aneurysms are often impalpable. Body habitus interferes, and a negative exam never rules out an aneurysm, which is exactly why screening relies on ultrasound rather than an annual physical. New or worsening pain in a known aneurysm is the most important warning sign in the whole condition. Discovering a pulsatile mass with a bruit means gentle assessment only, followed by notifying the provider and arranging imaging. Never repeated forceful palpation. Question 38. A patient with a known 6.1 cm abdominal aortic aneurysm suddenly reports severe tearing back pain. The blood pressure is 78/44, the heart rate is 136, and the skin is cool and clammy. Which set of actions should the nurse take? Your options are: A. Keep the patient supine and still. Establish 2 large bore intravenous lines. Ensure blood is typed and cross-matched. Keep the patient NPO and prepare for emergency surgery. B. Ambulate the patient to assess for reproducible pain, then obtain a routine abdominal series. C. Administer a rapid intravenous vasopressor infusion to raise systolic pressure above 128 mmHg before imaging. D. Position the patient in high Fowler's and encourage deep breathing while awaiting a scheduled surgical consult. Which would you go with? Lock it in before the reveal. The correct answer is A. Keep the patient supine and still. Establish 2 large bore intravenous lines. Ensure blood is typed and cross-matched. Keep the patient NPO and prepare for emergency surgery. A is correct because sudden tearing pain, hypotension, and a known pulsatile mass form the classic triad of rupture, which is a surgical emergency carrying roughly 80 to 90% mortality. Immediate priorities are minimizing movement, obtaining large bore access for massive resuscitation, securing cross-matched blood, maintaining NPO status, and mobilizing the surgical team. Every minute of delay costs blood volume. B is wrong because ambulating a patient in hemorrhagic shock risks syncope, injury, and further hemorrhage. Routine radiographs would waste time without answering the question. C is wrong because aggressively raising blood pressure before surgical control can worsen the hemorrhage, which is why permissive hypotension with a systolic roughly in the 70 to 90 range is often accepted pre-operatively. Driving the pressure to 140 mmHg works against survival. D is wrong because a scheduled consult is far too slow for a ruptured aneurysm, and positioning and breathing exercises do nothing for exsanguination. This patient needs the operating room now. 80 to 90% of patients whose abdominal aortic aneurysm ruptures will die, and many never make it to an operating room. That mortality is why rupture is diagnosed clinically. The surgical team mobilizes immediately, and resuscitation happens on the way to the OR rather than before it. When the aorta ruptures, blood tracks into the retroperitoneal space, and the surrounding tissue forms a tamponade that temporarily limits further bleeding. This fragile balance is exactly what the entire resuscitation strategy is built around protecting. Nursing actions follow a set order: keep the patient supine and still to avoid disturbing the tamponade. Establish 2 large bore IVs with blood typed and cross-matched. Monitor vitals continuously and keep the patient null by mouth, and notify the surgical team immediately. Blood pressure is deliberately kept low, around a systolic of 70 to 90 in a patient who is still awake and mentating. Aggressively normalizing pressure can blow out the clot and tissue tamponade containing the bleed, turning a contained rupture into a free one. Renal colic causes severe flank pain too, but it does not cause hypertension, marked tachycardia, or syncope. In an older patient with vascular risk factors, flank pain paired with instability means ruling out rupture before ever blaming a stone. Question 39. A patient with a 4.6 cemented abdominal aortic aneurysm is being followed conservatively. The patient asks which test will be used to track the aneurysm over time and which one would be needed if surgery becomes necessary. Which response is accurate? Your options are: A. Magnetic resonance angiography for surveillance and abdominal ultrasound for surgical planning. B. Abdominal ultrasound for surveillance and computed tomography angiography for surgical planning. C. Plain abdominal radiography for surveillance and Doppler ultrasound for surgical planning. D. Computed tomography angiography for surveillance and endoscopic evaluation for surgical planning. Don't overthink it. Which one feels right? The correct answer is B. Abdominal ultrasound for surveillance and computed tomography, angiography for surgical planning. B is correct because ultrasound is the surveillance workhorse because it measures diameter reliably without radiation or contrast, and it can be repeated every 6 to 12 months for moderate-sized aneurysms. Computed tomography angiography is the gold standard before repair because it defines size, shape, extent, and the relationship to the renal and iliac arteries. That anatomic detail determines whether endovascular repair is even feasible. A is wrong because magnetic resonance angiography is an alternative when contrast is contraindicated, not the routine surveillance tool. Ultrasound cannot supply the anatomic precision needed for surgical planning. C is wrong because plain films cannot measure an aortic aneurysm accurately, and Doppler assesses flow rather than mapping graft landing zones. Neither fills the role described. D is wrong because serial computed tomography angiography would deliver repeated radiation and contrast loads unnecessarily. Endoscopy visualizes the gastrointestinal lumen and has no role in aortic assessment. An abdominal aortic aneurysm raises two very different questions over its lifetime, and each one demands its own test. Confusing which study answers which question is one of the most common mistakes on this topic. The surveillance question, how fast is this growing, is asked repeatedly over years in a patient who feels fine, and it's answered by ultrasound. The planning question, what does this look like anatomically, is asked once before repair, and it's answered by CT angiography. Ultrasound measures aortic diameter reliably, costs little, and uses no contrast or radiation, so it can be repeated every 6 to 12 months for a decade without accumulating harm. That cumulative safety is exactly what serial CT scans would sacrifice in the same role. CT angiography defines size, shape, and extent precisely and critically, its relationship to the renal and iliac arteries. That relationship determines whether adequate landing zones exist for an endovascular stent graft, which is the single question deciding candidacy for the less invasive repair. CT angiography is more informative, and that is exactly why it's reserved for planning rather than monitoring. Reaching for it by default exposes patients to needless radiation and contrast risk, when ultrasound already answers the surveillance question just fine. Question 40. A patient returns to the surgical unit 6 hours after open abdominal aortic aneurysm repair. Which assessment finding requires the most urgent nursing action? Your options are A. A blood pressure of under 1870 with a heart rate of 82. B. Absent bowel sounds with a soft non-distended abdomen. C. Serous drainage on the abdominal dressing without saturation. D. A left foot that is cool, pale, and mottled with no palpable dorsalis pedis pulse. Got a guess? Lock it in. The correct answer is D. A left foot that is cool, pale, and mottled with no palpable dorsalis pedis pulse. D is correct because A cold, pale, pulseless extremity after aortic repair signals graft occlusion or distal embolization, and the affected limb is at immediate risk. The 6 P's of acute limb ischemia are pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. Comparing both legs against the preoperative baseline and notifying the provider urgently are the priority, since embolectomy may be needed. A is wrong because these vital signs sit comfortably inside the usual postoperative window, where systolic pressure is often kept around 100 to 130. That range perfuses the graft without stressing the suture lines. B is wrong because absent bowel sounds are expected early after abdominal surgery and resolve as gastrointestinal function returns. Mesenteric ischemia would present with dilatation, severe pain, bloody diarrhea, and acidosis, none of which are present. C is wrong because small amounts of serous drainage are normal in the early postoperative period. Saturated dressings, expanding hematoma, or frank bleeding would be the concerning findings. After abdominal aortic aneurysm repair, the single most important assessment happens at the foot of the bed, comparing one leg against the other. Preoperative nursing marks the femoral, popliteal dorsalis pedis and posterior tibial pulses on both legs. Without that baseline, a weak pulse after surgery is impossible to interpret. The threat being screened for is acute limb ischemia from either graft occlusion or a fragment of mural thrombus breaking free and lodging in the leg arteries. Skeletal muscle only tolerates a few hours of this before the damage becomes irreversible. The presentation is captured by the 6 P's: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, each reporting on a different tissue losing perfusion. Paresthesia and paralysis appearing together signal advanced ischemia and a limb in serious jeopardy. A single cool foot in a cold room means little, but a cool, pale, mottled foot beside a warm pink one means a great deal. That side-by-side comparison is what turns a subjective impression into an objective, documented finding, and it's where genuine deterioration shows up first. Question 41. A patient scheduled for elective repair of a 5.7 symmetry to abdominal aortic aneurysm asks why the surgeon prefers a stent graft placed through the groin rather than an open abdominal operation. Which response by the nurse is most accurate? Your options are: A. The stent graft approach is less invasive with faster recovery, but it requires lifelong follow-up imaging to watch for endoleak. B. The stent graft approach permanently removes the diseased segment of aorta, so no further monitoring is needed. C. The stent graft approach is used only when the aneurysm is already ruptured and open surgery is unsafe. D. The stent graft approach carries higher short-term mortality but eliminates the need for blood pressure control. Which one is it? Pause the video if you need more time. The correct answer is A. The stent graft approach is less invasive with faster recovery, but it requires lifelong follow-up imaging to watch for endoleak. A is correct because endovascular repair threads a stent graft up from the femoral artery and deploys it inside the aneurysm, creating a new channel so blood no longer pressurizes the weakened sac. It offers less blood loss, a shorter stay, and lower perioperative mortality, which is why it is preferred for elective repair in suitable anatomy. The trade-off is the risk of endoleak, blood flowing into the sac outside the graft, which makes lifelong surveillance imaging mandatory. B is wrong because the diseased aorta is left in place and simply excluded from the blood flow, which is exactly why the sac can repressurize. Open repair is the procedure that replaces the segment with a sewn-in synthetic graft. C is wrong because the relationship is the reverse. Open repair is the approach relied on an emergency rupture and an unfavorable anatomy, while endovascular repair is the elective preference. D is wrong because endovascular repair has lower short-term mortality, not higher. Blood pressure control remains essential after either operation to protect the repair. Choosing between endovascular and open aneurysm repair is a classic surgical trade-off. Lower short-term risk versus a lasting long-term obligation. In endovascular repair, a fabric-covered stent graft is threaded up from the femoral artery and deployed inside the aorta, creating a new channel for blood so the weakened sac is excluded from circulation rather than removed. EVAR's advantages are real: less blood loss, no aortic cross-clamping, shorter hospital stay, and lower perioperative mortality. But the cost is the endoleak, persistent blood flow repressurizing the sac, which is why lifelong surveillance imaging becomes a genuine nursing responsibility. Open repair takes the opposite trade-off. Cross-clamping the aorta and sewing in a synthetic graft gives a definitive, durable repair usable in any anatomy or emergency rupture, but at the cost of greater blood loss and higher cardiac, pulmonary, and renal stress. The key misconception is that endovascular repair improves long-term survival. It doesn't. Its mortality edge is only in the perioperative period, converging over time as endoleaks and re-interventions catch up. Question 42. A nursing student asks how the liver handles a normal therapeutic dose of acetaminophen without any injury. Which explanation is correct? Your options are: A. The entire dose is excreted unchanged by the kidneys without any hepatic processing. B. The drug is stored in hepatocytes until it is slowly released back into the circulation. C. Roughly 90% is safely conjugated by glucuronidation and sulfation, while the small fraction converted to NAPQR is neutralized by glutathione. D. The drug is converted entirely to NAPQR, which the kidneys filter and excrete in the urine. Take a second. Which answer would you pick? The correct answer is C. Roughly 90% is safely conjugated by glucuronidation and sulfation, while the small fraction converted to NAPQR is neutralized by glutathione. C is correct because at therapeutic doses, glucuronidation handles roughly 50 to 60% and sulfation another 30 to 40%, both producing harmless water-soluble metabolites. Only about 5 to 10% passes through the cytochrome P450 system, chiefly CYP2E1, to become the reactive metabolite NAPQR. Glutathione binds that NAPQ immediately, converting it to harmless conjugates excreted in the urine, so no injury occurs. A is wrong because a small fraction is excreted unchanged, but the bulk of the drug is metabolized by the liver. Acetaminophen is a classic example of first-pass hepatic metabolism. B is wrong because the liver does not warehouse acetaminophen for later release. It conjugates the drug and moves the metabolites toward renal excretion. D is wrong because NAPQR is a minor metabolite under normal conditions, and it is neutralized in the liver rather than filtered intact by the kidneys. If the whole dose became NAPQR, every therapeutic dose would be hepatotoxic. Acetaminophen is safe at normal doses not because it's a harmless molecule, but because the liver has a metabolic system built with substantial spare capacity. Understanding that system is the key to understanding toxicity. The liver receives a dual blood supply. The hepatic artery brings oxygenated blood, while the portal vein brings blood absorbed from the entire gut, roughly 70 to 75% of total flow. That means every oral medication passes through the liver first, making it both the main site of drug processing and the main site of drug-induced injury. 3 pathways process the drug: glucuronidation and sulfation, both safe phase 2 reactions. Together handle about 90%, producing harmless water-soluble metabolites. The remaining 5 to 10% goes through the cytochrome P450 enzyme CYP2E1, a phase 1 reaction that produces the reactive toxin NAPQR. Glutathione, an antioxidant stored in liver cells, binds NAPQR the instant it forms, converting it into harmless compounds excreted in urine. At normal doses, the small trickle of NAPQR is neutralized as fast as it's produced, so the system isn't avoiding the toxic metabolite. It's continuously making and disposing of it. NAPQR exists at every dose, even the one taken for a headache last week. Overdose isn't a new chemical process. It's the same process with production outrunning glutathione supply. And that single distinction makes the entire clinical picture predictable. Question 43. A patient ingests 30 grams of acetaminophen in a single act of self-harm. Which sequence best describes how this dose produces liver injury? Your options are: A. The drug directly dissolves hepatocyte membranes on contact, causing immediate necrosis throughout the liver. B. The drug obstructs the hepatic artery, producing ischemic infarction of the entire right lobe. C. The drug triggers an immune-mediated hepatitis with antibody attack on bile ducts. D. The conjugation pathways saturate. More drug is shunted to the cytochrome P450 system. Now PQR production surges and depletes glutathione, and unbound NRPQ destroys hepatocytes. Before I reveal it, which one do you think is right? The correct answer is D. The conjugation pathways saturate. More drug is shunted to the cytochrome P450 system. NAPQR production surges and depletes glutathione, and unbound NAPQR destroys hepatocytes. D is correct because in overdose, glucuronidation and sulfation are overwhelmed, so a much larger share of drug is routed through cytochrome P450 to NAPQR. The surge in NAPQR rapidly consumes glutathione, and once stores fall below roughly 30% of normal, there is not enough left to neutralize what is being formed. Unbound NAPQR then binds cellular proteins and generates oxidative stress, killing hepatocytes in the centrolobular zone 3 region where P450 activity is highest. A is wrong because acetaminophen itself is not directly cytotoxic, which is why therapeutic doses are safe. Injury requires conversion to the reactive metabolite. B is wrong because the liver has a dual blood supply and acetaminophen does not occlude the hepatic artery. Its injury pattern is metabolic and zonal, not the wedge of an infarct. C is wrong because immune-mediated bile duct injury describes conditions such as primary biliary cholangitis. Acetaminophen produces direct toxic hepatocellular necrosis instead. The real danger in acetaminophen overdose isn't swallowing the pills. It's the moment the liver's glutathione supply falls behind NAPQR production, and everything that matters clinically follows from that single crossing point. First, the normal safe pathways, glucuronidation and sulfation, become saturated by the massive dose. Second, the drug shifts to the cytochrome P450 system, which normally handles only a small fraction of the load, and NAPQR production surges. Third, glutathione stores get consumed neutralizing that surge until they run low. Once glutathione falls below about 30% of normal, free NAPQR binds proteins and destroys mitochondria. But the damage isn't spread evenly. It concentrates in the centrolobular region, or zone 3, because that area has the most cytochrome P450 enzyme and the least oxygen, making it the most vulnerable and the site of the classic necrosis. Once enough hepatocytes die, every liver function fails in a predictable pattern. Clotting factors drop, raising the PT and INR, glucose synthesis stops, causing hypoglycemia, ammonia builds up, driving encephalopathy, and bilirubin backs up into jaundice. You can predict the whole lab picture just by knowing what the liver normally does. This direct chemical toxicity is dose-dependent and predictable, which is exactly why a nomogram can forecast it from a blood level, unlike immune-mediated hepatitis, which is unpredictable and has no such tool. Question 44. A patient treated at home for a severe sinus infection took an over-the-counter cold remedy every 6 hours, plain acetaminophen for headache, and a prescribed opioid acetaminophen combination for tooth pain over 4 days. The patient now has right upper quadrant tenderness and an ALT of 1/850 UL. Which statement best explains what happened? Your options are: A. Combining these products creates a chemical interaction that produces a new hepatotoxin not present in any one drug. B. The patient unknowingly exceeded the 4-gram daily maximum by taking several products that each contain acetaminophen. C. The opioid component is the hepatotoxin and the acetaminophen in the products is incidental. D. Toxicity at these doses is possible only with a single large intentional ingestion. What's your answer? Commit to one before I continue. The correct answer is B. The patient unknowingly exceeded the 4-gram daily maximum by taking several products that each contain acetaminophen. B is correct because unintentional overdose most often happens exactly this way, through repeated supratherapeutic dosing from multiple products that all contain acetaminophen. The drug is hidden in hundreds of cold, flu, sinus, sleep, and prescription pain combinations, often labeled APAP. The maximum for a healthy adult is 4 grams in 24 hours, and stacking products makes that ceiling easy to blow through without realizing it. A is wrong because there is no novel toxin created by combining these products. The injury comes from the cumulative acetaminophen dose overwhelming the same metabolic pathways. C is wrong because opioids cause sedation and respiratory depression, not hepatocellular necrosis with transaminases in the thousands. The acetaminophen component is the liver toxin. D is wrong because chronic and staggered supratherapeutic dosing causes toxicity as well, particularly in patients with additional risk factors. Restricting suspicion to single large ingestions misses a large share of cases. 4 grams in 24 hours. That's the maximum daily dose of acetaminophen for a healthy adult. And it's easier to cross than most people think. The danger is that acetaminophen hides everywhere, often abbreviated APAP, tucked into cold remedies, sinus medications, sleep aids, and opioid combinations. A patient can stack several of these products for a bad week of symptoms and cross 4 grams without ever intending to overdose. Repeated excess dosing over days is called therapeutic misadventure, distinct from intentional overdose, which is usually one large ingestion. Both cause the same liver injury, but the early phase is nearly silent, so feeling fine is never proof of safety. Beyond the daily maximum, a single ingestion of 150 milligrams per kilogram, roughly 7.5 to 10 grams in an adult, is potentially toxic to the liver and warrants evaluation, with even lower ceilings for at-risk patients. The single most important teaching point: seek emergency care the moment overdose is suspected without waiting for symptoms, because by the time acetaminophen makes you feel sick, the antidote's best window may already be closing. Question 45. A malnourished patient with a long history of daily heavy alcohol use has been taking acetaminophen at 3 grams per day for chronic knee pain. The nurse recognizes this patient is at elevated risk for hepatotoxicity even at this dose. Which explanation is correct? Your options are: A. Alcohol slows gastric emptying so the entire day's dose is absorbed at once. B. Alcohol blocks renal excretion of acetaminophen conjugates, allowing the parent drug to accumulate. C. Alcohol induces the cytochrome P450 enzyme CYP2E1, increasing NAPQI production, and it also depletes glutathione stores. D. Alcohol competes with acetaminophen for the same receptor sites on hepatocyte membranes. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Alcohol induces the cytochrome P450 enzyme CYP2E1, increasing NAPQI production, and it also depletes glutathione stores. C is correct because chronic alcohol use delivers a double hit. It upregulates CYP2E1, so a larger share of each dose becomes NAPQ, and it simultaneously drains the glutathione reserves needed to neutralize that NAPQI. Malnutrition compounds the problem because glutathione synthesis requires nutritional substrate, which is why a dose within the usual ceiling can still injure this patient's liver. A is wrong because altered gastric emptying does not change the total daily dose or the metabolic capacity of the liver. The risk here is metabolic, not a matter of absorption timing. B is wrong because renal excretion of the safe conjugates is not the rate-limiting step, and alcohol does not block it. The bottleneck is hepatic glutathione supply. D is wrong because acetaminophen toxicity is not receptor mediated, and there is no competition for binding sites. Injury comes from a reactive metabolite attacking cellular proteins. A patient taking 3 grams of acetaminophen a day, well under the 4 gram ceiling, can still develop liver injury. The dose wasn't wrong. What was wrong was assuming the ceiling applies the same way to everyone. Chronic alcohol use damages the system from both ends. It induces the enzyme CYP2E1, so more of the drug converts to the toxic metabolite NAPQR, while simultaneously depleting glutathione, the very defense that neutralizes it. That's why lower limits, often 2 grams daily, are recommended for chronic drinkers. Normally, a small fraction of acetaminophen becomes NAPQR, and glutathione mops it up before harm occurs. Malnutrition and fasting attack the glutathione side alone, since synthesis requires nutritional substrate like cysteine, and fasting also depletes glucuronidation capacity. An ill patient eating little while taking acetaminophen for fever is accumulating risk on both fronts. Pre-existing liver disease, enzyme-inducing medications like some anticonvulsants, and simple concurrent use of multiple acetaminophen-containing products or lower the safety threshold further. Good nursing practice means asking about all medications, alcohol intake, and nutritional status, since a patient describing daily drinking and poor appetite is describing a setup for injury. Remember the mechanism, not a slogan. Acute alcohol intake can actually compete with acetaminophen for the same enzyme and be mildly protective. It's chronic use through enzyme induction and glutathione depletion that creates real danger, and that distinction is what identifies the truly vulnerable patient. Question 46. A patient arrives in the emergency department 8 hours after ingesting a large quantity of acetaminophen. The patient is alert, has normal vital signs, denies pain, and has normal liver function tests. Which nursing action is most appropriate? Your options are: A. Proceed with obtaining the timed acetaminophen level and anticipate starting N-acetylcysteine, since the early phase is deceptively silent. B. Reassure the patient that normal liver enzymes at 8 hours rule out significant injury and prepare for discharge. C. Withhold all treatment until right upper quadrant pain and jaundice appear. D. Repeat the liver function test in 12 hours and base the treatment decision entirely on the second set of results. Which would you go with? Lock it in before the reveal. The correct answer is A. Proceed with obtaining the timed acetaminophen level and anticipate starting N-acetylcysteine, since the early phase is deceptively silent. A is correct because stage 1 of acetaminophen toxicity spans the first 24 hours and is frequently asymptomatic with normal liver function tests, even while lethal injury is underway. Treatment decisions rest on the timed serum acetaminophen level and the nomogram, not on how the patient looks or feels. N-acetylcysteine works best when given early, so waiting for the picture to declare itself squanders the window. B is wrong because normal enzymes at 8 hours are entirely expected and prove nothing about the ingested dose. Discharging this patient would send home someone heading into stage 2 hepatic injury. C is wrong because right upper quadrant pain and jaundice mark stages 2 and 3, by which point substantial hepatocyte death has occurred. The antidote is far less protective at that point. D is wrong because serial enzymes are useful for trending established injury, but delaying the decision 12 hours pushes treatment well past the most effective window. The acetaminophen level and nomogram guide the decision now. Acetaminophen toxicity's most dangerous feature is that the patient feels fine. Someone can be hours from irreversible liver injury while looking and feeling completely well with normal labs to match. That silence is exactly what kills people who had plenty of time to be saved. The course unfolds in 4 stages. Stage 1, 0 to 24 hours, is often symptom-free with normal enzymes. Stage 2, 1 to 3 days, brings rise in transaminases and right upper quadrant pain even as symptoms may briefly improve. Stage 3, 3 to 4 days, is fulminant hepatic failure with jaundice, encephalopathy, and bleeding. Stage 4 is recovery, since the liver can regenerate completely if enough hepatocytes survive. Picture the liver itself moving through this timeline, healthy and quiet in stage 1, swelling and leaking enzymes in stage 2, failing outright in stage 3, then regenerating in stage 4. The liver's unusual regenerative capacity means survivors of stage 3 often recover completely, not partially. The single most important teaching point: treatment decisions rest on the timed serum, acetaminophen level, and the nomogram, never on how comfortable or symptom-free the patient appears. By the time symptoms emerge in stage 2 or 3, the antidote's protective window has largely closed. A calm, alert patient with normal enzymes 8 hours after a big ingestion is precisely who needs treatment right now. Remember, nausea and malaise can mimic ordinary gastroenteritis, but a plausible ingestion history demands a timed level regardless of how mild the patient seems. Treat the number, not the appearance. Question 47. A patient presents 2 hours after a single acute acetaminophen ingestion at a clearly known time. The provider orders a serum acetaminophen level. Which statement about the Rumack-Matthew Nomogram should guide the nurse's understanding? Your options are: A. The level should be drawn immediately, since earlier levels are more accurate. B. The nomogram applies to any ingestion pattern, including staggered dosing over several days. C. The nomogram remains valid for up to 72 hours after ingestion. D. The level must be drawn no earlier than 4 hours after ingestion, and the nomogram is valid only from 4 to 24 hours after a single acute ingestion. Don't overthink it. Which one feels right? The correct answer is D. The level must be drawn no earlier than 4 hours after ingestion, and the nomogram is valid only from 4 to 24 hours after a single acute ingestion. D is correct because before 4 hours, absorption is still incomplete and the serum level does not yet reflect the true peak. So plotting it would underestimate risk. The nomogram is valid only in the 4 to 24 hour window following a single ingestion at a known time, a level on or above the treatment line, which begins at 150 micrograms per milliliter at 4 hours, indicates the need for the antidote. A is wrong because an early level is misleadingly low because the drug has not finished absorbing. Waiting to the 4-hour mark is what makes the value interpretable. B is wrong because the nomogram does not apply to staggered or chronic ingestions, to unknown ingestion times, or to extended release preparations. In those situations, clinicians rely on the level, liver function test, and clinical judgment, and they err toward treating. C is wrong because past 24 hours the nomogram loses validity, and decisions shift to laboratory trends and the clinical picture. Extending it to 72 hours would misapply the tool. The Rumack-Matthew Nomogram plots serum acetaminophen concentration against hours since ingestion, with a treatment line that predicts hepatotoxicity. But this graph only works under specific conditions, and most errors with it come from misapplying it rather than misreading it. 3 rules govern its use. First, the level must be drawn no earlier than 4 hours, since absorption is incomplete before then. Second, the tool is only valid from 4 to 24 hours after a single acute ingestion. Third, it was never designed for unknown ingestion times, staggered or chronic dosing, or extended release preparations. The treatment line starts at 150 micrograms per milliliter at 4 hours and declines along the drug's elimination curve. Any level plotted on or above that line within the valid window means treatment is indicated, and the line is drawn conservatively on purpose. The most common confusion is thinking that waiting 4 hours to draw the level means waiting to act, when a substantial ingestion is suspected or the case falls outside the nomogram's design. Say acetylcysteine is started immediately and can be stopped if the level later comes back below the line. Unlike a vancomycin trough interpreted against a fixed target, the nomogram predicts future injury from a single exposure and only within its narrow time window. Because the antidote is safe and loses effectiveness with every passing hour, the risk always favors early treatment. Question 48. A patient with a toxic acetaminophen level and persistent vomiting is to receive N-acetylcysteine. Which statement about this antidote is accurate? Your options are: A. It binds acetaminophen in the stomach to prevent absorption and is useless once the drug has been absorbed. B. It replenishes glutathione so the liver can neutralize NAPQR, and it is most effective within 8 to 10 hours of ingestion. C. It reverses established hepatic necrosis and regenerates dead hepatocytes within 24 hours. D. It should be withheld in patients who present more than 8 hours after ingestion since the window has closed. Got a guess? Lock it in. The correct answer is B. It replenishes glutathione so the liver can neutralize NAPQR, and it is most effective within 8 to 10 hours of ingestion. B is correct because N-acetylcysteine restores hepatic glutathione and supplies cysteine as a building block, directly reversing the deficit that allows NAPQR to attack hepatocytes. It also enhances the safe sulfation pathway and acts as a free radical scavenger. Timing is the single most important variable, and given within 8 to 10 hours, it is nearly always protective against serious hepatotoxicity. A is wrong because activated charcoal is the agent that absorbs drug in the gut, and it is useful only within roughly 1 to 2 hours of ingestion. N-acetylcysteine works systemically inside the hepatocyte. C is wrong because the antidote prevents further injury rather than resurrecting dead cells. Recovery in stage 4 depends on hepatocyte regeneration over days to weeks. D is wrong because benefit persists beyond the ideal window because of the antioxidant and microcirculatory effects, so it is still given to late presenters and to patients with established injury. It is never assumed to be too late to help. The intravenous route is preferred for this patient who cannot retain oral dosing. N-acetylcysteine was designed to fit the mechanism of acetaminophen poisoning so closely that you can reason it out from the pathophysiology itself. If NAPQR production has outrun glutathione supply, the solution is simply to restore glutathione, and that is exactly what this drug does. Its actions reinforce one another. It replenishes hepatic glutathione by supplying cysteine, can substitute for glutathione directly by binding NAPQR, enhances the non-toxic sulfation pathway, and acts as a direct antioxidant that improves microvascular oxygen delivery, which is why it still helps patients with established injury. Activated charcoal is often confused with the antidote, but it does something entirely different. Charcoal adsorbs drug still sitting in the gastrointestinal tract and only helps very early, within 1 to 2 hours of ingestion, and acetylcysteine works systemically inside the hepatocyte on drug already absorbed, so a late presenting patient still has something left to offer. Timing within 8 to 10 hours gives excellent protection, and that urgency is why the nomogram is built for a fast decision rather than a perfect one. Though benefit never truly disappears. Oral N-acetylcysteine runs a 72-hour protocol but tastes foul and provokes vomiting, while intravenous dosing runs about 21 hours and is preferred for patients who can't tolerate oral dosing, who are in fulminant failure, pregnant, or presenting late. During IV loading, anaphylactoid reactions like flushing and bronchospasm can occur, but these are rate-related rather than true allergy. The right response is to slow or briefly pause the infusion and give antihistamines, never to abandon the only drug that can still help. Question 49. A patient with acetaminophen-induced acute liver failure has an INR of 7.2 and is actively bleeding from the gums and intravenous sites. Which intervention should the nurse anticipate first? Your options are A. Fresh frozen plasma because it supplies clotting factors immediately. B. Subcutaneous vitamin K because it is the definitive correction for a prolonged INR. C. An additional loading dose of N-acetylcysteine to stop the hemorrhage. D. Oral lactulose to reduce the ammonia contributing to the coagulopathy. Which one is it? Pause the video if you need more time. The correct answer is A. Fresh frozen plasma because it supplies clotting factors immediately. A is correct because the failing liver has stopped producing clotting factors and a bleeding patient needs those factors now. Fresh frozen plasma delivers them directly and works within minutes, which is why it is first line for active hemorrhage. Recognizing when to treat the consequence rather than the cause is the distinction being tested here. B is wrong because vitamin K is a useful adjunct, but it works slowly and depends on residual hepatocyte capacity to synthesize the factors. In fulminant failure, that capacity is precisely what is missing. C is wrong because N-acetylcysteine treats the underlying toxic mechanism by restoring glutathione. It does nothing to replace absent clotting factors or stop bleeding that is already occurring. D is wrong because lactulose lowers ammonia and treats hepatic encephalopathy, not coagulopathy. Ammonia does not cause the bleeding. When a liver failure patient is actively bleeding, 4 treatments look reasonable, but only one works within minutes. The key to sorting them out is separating treatment of the cause from treatment of the consequence. The coagulopathy exists because the liver manufactures nearly all clotting factors, and factors 2, 7, 9, and 10 need vitamin K for their final activation step. Factor 8 is the exception, made by endothelial cells, which is why it can help distinguish liver failure from DC. When hepatocytes die, factor production simply stops. Fresh frozen plasma works within minutes because it supplies finished clotting factors directly, restoring hemostatic capacity without asking the liver to do anything. Vitamin K only helps hepatocytes finish activating factors 2, 7, 9, and 10, so it is useless if those hepatocytes are already dead. Acetylcysteine protects surviving liver cells and treats the poisoning, but it cannot replace factors that are already gone. Picture the hepatocyte as the factory floor. Vitamin K is a cofactor helping finish factors 2, 7, 9, and 10, but factor 8 is built next door in the endothelium. Fresh frozen plasma bypasses the whole factory by delivering the finished product straight into the bloodstream. The INR is one of the most important prognostic markers in acetaminophen liver failure, so correcting it with plasma raises a signal doctors rely on for transplant decisions. That's why plasma is reserved for active bleeding or invasive procedures, while bleeding precautions like gentle care and pressure after punctures quietly reduce how often it's needed at all. Question 50. A patient with acetaminophen-induced liver failure becomes increasingly confused and irritable, and the nurse observes a flapping tremor of the hands when the patient extends the wrists. Which combination of interventions should the nurse anticipate? Your options are A. Administer intravenous lorazepam for agitation and restrict all oral intake. B. Administer a high-protein supplement and encourage frequent ambulation. C. Administer lactulose titrated to 2 or 3 soft stools daily and avoid sedatives and other central nervous system depressants. D. Administer intravenous vitamin K and place the patient in a darkened room without further monitoring. Take a second. Which answer would you pick? The correct answer is C. Administer lactulose titrated to 2 or 3 soft stools daily and avoid sedatives and other central nervous system depressants. C is correct because asterixis with confusion signals hepatic encephalopathy driven by ammonia, the failing liver can no longer convert to urea. Lactulose acidifies the colon, trapping ammonia as ammonium for excretion, and produces catharsis that clears ammonia-generating gut contents, with 2 to 3 soft stools daily as the therapeutic target. Sedatives and opioids must be avoided because they deepen encephalopathy and mask the neurologic deterioration the nurse is watching for. A is wrong because benzodiazepines worsen encephalopathy and obscure the mental status changes used to track the patient's course. Sedity in this patient would be actively harmful. B is wrong because protein loading increases the ammonia burden the liver cannot process. Ambulation is also unsafe in a confused patient at high risk of falls and bleeding. D is wrong because vitamin K addresses coagulopathy slowly and does nothing for ammonia, reducing monitoring in a patient who may be progressing towards cerebral edema and coma is the opposite of what is needed. Asterixis is not a tremor at all, but a brief lapse in sustained muscle contraction, a negative myoclonus that shows up as flapping when the wrists are held extended. It is one of the most specific bedside signs of hepatic encephalopathy. Gut bacteria produce ammonia from protein breakdown, and it normally travels through the portal vein where hepatocytes convert it to urea for excretion. When enough hepatocytes die, ammonia builds up, crosses the blood-brain barrier, and disrupts astrocyte function, producing the neurologic decline called hepatic encephalopathy. Lactulose works 2 ways. It acidifies the colon so ammonia converts to ammonium and gets trapped and excreted, and it causes catharsis, physically flushing ammonia-generating contents from the gut. The target is 2 to 3 soft stools daily, titrated carefully since too much causes dehydration. Alcohol withdrawal is easily confused with hepatic encephalopathy since both cause confusion and tremor, but withdrawal produces a fine, rhythmic, sustained tremor with autonomic hyperactivity, unlike the irregular flapping of asterixis. This distinction matters because withdrawal is treated with benzodiazepines, while those same drugs worsen encephalopathy and mask the very neurologic status clinicians must track. Avoiding sedatives is treated as strongly as giving lactulose, because masking neurologic status removes the only window into a patient who can slide towards cerebral edema and death. Frequent neurochecks aren't routine charting here, they are surveillance for a lethal complication. That brings our Q&A session on acute gastrointestinal, vascular, and toxicologic emergencies to a close. Now, to start putting this into practice, head over to our website using the link in the description below. Once you're there, you'll find hundreds of free practice questions plus complete, easy-to-follow study guides covering everything you need. It's all organized and ready for you, so go ahead and dive right in whenever you're ready to begin. Hit subscribe to catch the next video in this series, and good luck on your Adult Health 3 exam.